Hello, everyone, and welcome. I'm Debbie Plotnick. I'm Vice President for State and Federal Advocacy at MHA National, and we're so glad that you could join us today. let me do something really important as we get started. And in addition to welcoming everyone, telling you that all the slides will be available after today's meeting, it will also be recorded and you'll be able to share it and watch it or check in and listen to sessions again. I would really like to thank our industry partners who help make our regional policy council meetings possible. And they are Janssen, Neurocrine, Myriad, Pfizer, Sage, Otska, Alkermes, Takeda Lundbeck, and Teva. We're going to do a number of things today, but it's really my privilege to start us off by once again introducing MHA's brand new President and CEO, Schroeder Stribling. And you can read Schroeder's whole biography on the MHA website or on this meeting's link. But we are so happy to have her. She's a lifelong social justice advocate, and she has over 20 years of experience in managing organizations that focus on mental health, on homelessness, on poverty, and on racial justice. Let's hear from Schroeder.
Hello and welcome to the August 3rd Regional Policy Council meeting, From Deflection to Prevention. I am welcoming you as the new President and CEO of Mental Health America. My name is Schroeder Stribling, and I recently started here at MHA after spending 18 years running a nonprofit here in Washington, D.C., which provided housing and supportive services to about 2,000 women every year experiencing homelessness here in our region. I know well how important it is to have effective policies to address people with mental health needs in community-based care. Today, we welcome Mental Health America affiliates, industry partners who make these meetings possible, and local and state policymakers and advocacy partners all gathered here today. Special congratulations are due to all the mental health and substance use legislative champions who are being honored today and also were honored on July 28th. Our focus today is on youth and the outstanding work that the MHA staff and the Regional Policy Council representatives are doing to further the imperative to act on our Stage 4 platform. Today, you will hear examples of state and local initiatives from the MHA affiliate field related to our deflection to prevention topic and our focus on youth and young adults. You'll learn what MHA screening has documented and hear about the explosion of need, especially during and since the pandemic. Today's meeting will present the findings of MHA's nationwide survey of those who serve youth and young adults in schools, as well as policy recommendations and models for providing mental health education and policy which addresses the needs of young people. You are the champions of this message, and we are grateful for your participation. And I am glad to meet you virtually, and I look forward to meeting you in person.
Oops, muted. Sorry, everybody. You just got to see me moving my mouth. We're about to hear from Carmen Hansen from NCSL, and we're delighted that she's here today as we thank and honor the rest of this summer's MHA state legislative champions. Carmen?
Hi, I'm Carmen Hansen, Associate Director for Behavioral Health and Pharmaceutical Policy at the National Conference of State Legislatures, coming to you from our headquarters city of Denver, Colorado. I'd like to thank Mental Health America for inviting NCSL today as they recognize state legislators working on mental health policy in their states. As a bipartisan organization, NCSL appreciates the work done by all legislators on issues important to their constituents. And if the last 18 months has taught us anything, it's that no one is immune to how dramatic life changes can affect our mental health. NCSL has noted hundreds of mental health related bills from legislators from across the country and political spectrum. While all measures may not pass, many do with strong bipartisan support. And this is one area where we see legislatures truly coming together and meeting the needs of their states and constituents. You've accomplished goals like establishing new mental health caucuses and prioritizing mental health and suicide prevention in schools and workforces. You're providing screenings in maternal and pediatric settings and assisting people with housing subsidy applications. You're even enforcing compliance with federal parity laws, which is an accomplishment in itself, and establishing new state offices of behavioral health promotion and prevention. And that is just a small, impressive slice of what you all have done over the last year. We really miss working face-to-face with the 7,383 state legislators and 30,000 legislative staff across the country. It has been a very long 18 months, and we can't wait to see you at another event soon, hopefully at NCSL's online base camp, August 3rd through the 5th, or in person at the NCSL Legislative Summit in Tampa, November 3rd through the 5th. In the meantime, if there's anything NCSL can help you with in your work as legislators, please don't hesitate to reach out with your questions, and you can find us at ncsl.org. Thanks again to Mental Health America for including NCSL in your celebration, and congratulations to all of the legislators on your work and your recognition. Thank you, and we will see you soon.
Hi, my name is Megan Reed, and I am with Mental Health America of Greater Dallas. We're extremely excited to nominate Representative Tony Rose for Mental Health America's 2021 Legislative Champion Award. Representative Rose represents District 110 here in South Dallas. This last legislative session, she fought for funding for the reestablishment of the Office of Minority Statistics, and which would look to research the disparities of our most vulnerable populations. And she was able to pass House Bill 133, which would expand Medicaid coverage for postpartum mothers up to 6 months. We all know that Texas mothers are most vulnerable in this time and need mental health care so that they're able to live their lives and also care for their children. Thank you, Representative Tony Rose, for all the extensive work that you and your office has done to advocate for mental health and to ensure that our communities, especially our communities of color, are protected and have the mental health care they need. Thank you so much.
Hello, I am State Representative Tony Rose, and I represent Texas House District 110 in the state of Texas. I am deeply honored to receive the 2021 Mental Health America Legislative Champion Award. I would like to take this opportunity to thank Mental Health America of Dallas for nominating me for this prestigious award. You don't know how much this means to me personally and professionally. I spent my entire career working in mental health spaces and strive to be the difference for individuals who not only live with the daily challenges of mental illness, but for those who also provide treatment and personal support. Each of you understand that mental health is often a form of healthcare least considered for funding by legislative bodies around the nation, but one that intersects with education, the criminal justice system, housing, the economy, and literally every aspect of society in our daily lives. We know that our work is not done. In many ways, it feels that we've just begun to turn the corner in educating and gaining a listening ear to lawmakers and opinion leaders. We know that our work is not done. In many ways, it feels that we've just begun to turn the corner in educating and gaining a listening ear of lawmakers and opinion leaders. I want to encourage each of you to keep up the magnificent work and to keep in mind that lawmakers need your steady hand in understanding mental health. I promise you that mental health will always remain in the upper echelon of policy concerns, and I will keep fighting to make things better for everyday Texans. Thank you for your time, thank you for your efforts, and thank you for your heart that you pour into every aspect of your work. I know you take your work home. I know you lay awake at night working through how to make things better. I know you have to fight to gain and maintain funding for programs that are so vital to those that you serve. Keep fighting. There is hope on the horizon, and we'll get there together. Take care, and again, thank you for this prestigious honor.
Mental Health America of Greater Dallas is extremely excited to nominate Representative Julie Johnson for Mental Health America's Legislative Champion Award for 2021. Representative Julie Johnson represents District 115 here in North Dallas County. Her continuous work on the legislative floor included bills on telehealth to improve telehealth access and coverage for private insurers. She also introduced the most incredible legislation for the Live Well Texas bills. These bills would expand Medicaid with a Texas plan to ensure that millions of Texans would be covered within the Texas coverage gap. She is a continuous advocate for mental health for not only for all Texans, but also for the LGBTQ plus communities. Without her advocacy, many would be left behind, and we're extremely honored to have her as our representative. Thank you.
I'm Julie Johnson, and I am so honored and grateful to be nominated for the 2021 Legislative Champion Award today. Thank you to the Greater Dallas chapter of Mental Health America for the nomination and for the critical work you do in promoting mental health in our community. As a state representative for House District 115, equity and access to mental health services for Texans is an issue I am very passionate about and have fought to advance since I was first elected in 2018. In my first session while on the House Insurance Committee, I fought for healthcare access and affordability. And for my second session, I found myself in a new role on the Appropriations Committee. I served in the subcommittee that oversees Health and Human Services and was able to fight for and secure critical funding for mental health services. The session, I was proud to have authored House Bill 4, known as the Telehealth Bill, which expands access to telehealth options implemented during the pandemic to become permanent fixtures in the healthcare system. During the COVID-19 pandemic, telehealth options have helped to ensure Texans across the state can continue to access healthcare services, including therapy and other mental health resources when more people than ever are experiencing anxiety, depression, and poor mental health. Some of the provisions of this bill include increased care in rural areas by allowing rural health centers to bill for telehealth services, allowing the Texas Health and Human Services Commission to implement audit-only benefits for behavioral health services, and allowing Medicaid to send text messages to these clients. These provisions will help to ensure that even after this unprecedented public health emergency, Texans have more accessible and affordable options for mental health services that meet their needs. Of course, expanded telehealth needs access to reliable, affordable internet. Another bill I co-authored was House Bill 5, was signed by the governor, and on June 15th will rapidly increase broadband access in our state. As we all saw during the pandemic, access to the internet was crucial for maintaining healthcare appointments, working remotely, and attending school. This bill, which I supported and signed onto, creates a state broadband development office, a statewide broadband plan, and a broadband development program that will award grants, low-interest loans, and other financial incentives to expand broadband access and adoption, creating the internet access Texans need to benefit from for telehealth services and find the mental health resources they so desperately need. With the ongoing disparities individuals face in regards to healthcare access and affordability, in addition to the expected impacts of COVID-19, both physically and mentally in years to come, there is definitely more work to be done moving into the future. I look forward to being an advocate for those struggling by supporting and filing legislation to advance mental health access and talking about mental health itself to overcome the stigma of seeking care, which is often the biggest roadblock. Thank you again for this great honor and for your efforts to promote mental health across Texas and the nation. I very much appreciate it.
As I'm recording this, the Texas Legislature is in its first special session of the 87th Legislature. Senator Powell and many of her Democratic colleagues in the Senate have just returned to Austin after joining Democratic House members in Washington, D.C. The House Democratic Caucus has broken quorum to delay what is now known as SB 1, the voter protection bill from being heard on the House floor. During the regular session, Senator Powell played a significant role in the tug of war between Democrats and Republicans over the issue of election integrity. Each chamber passed a version of the elections bill, and a conference committee was formed to reconcile the two documents. Powell served as the only Senate Democrat on the conference committee, chosen because of her integrity and her steadfast commitment to protecting her community. The fate of the elections bill in Texas remains unknown, but Senator Powell's integrity and steadfast commitment to protecting her community is what I hope to be able to convey in these brief remarks. Senator Powell was born in Fort Worth, Texas, and grew up in Burleson County. As it is important to mention when talking about anyone in this state, Beverly Powell is a lifelong fourth-generation Texan. She is the daughter of a school teacher and found her place in education as well. She attended Texas Wesleyan University, where she would ultimately become a member of the university's Board of Trustees. And prior to her election, she served as the president of the school board of Burleson ISD. When she was elected, Senator Powell brought with her the concerns and the lessons learned by being not only an educator, but also attending Burleson ISD, her experiences in Fort Worth at university, and everything that she'd learned as serving on the Board of Trustees as well as the school board. She is a champion of education here in the Texas Senate, and that is becoming increasingly difficult to find. I met Senator Powell in 2019. We had been talking about doing a mental health bill, and we wanted to connect it to students. And somehow Senator Powell heard that we were doing it. She came to us and asked to carry a bill relating to school-based mental health because she understood its importance. Throughout the 2019 legislative session, she fought so hard. I was surprised and impressed and don't know if I've ever worked with a legislator who championed an issue as bravely as she did. We passed our bill in 2019. It's HB 906, and it established a task force to evaluate the state-funded school-based mental health supports. Basically, we wanted to make sure the state of Texas is investing in the right programs. This year, I got a call in about August from her office, and Senator Powell had called very upset regarding the increasing number of suicides on elementary school campuses. She wanted to do something about the problem, and she understood that there were not enough support in elementary schools in place to prevent and intervene in these incidents before they occur. We worked with her during the 87th legislative session on HB 2954, which would establish a grant program to fund campuses who have experienced a death by suicide of a student, and to use this grant money to support those students remaining on that campus. We also worked with her on HB 2287, which was a follow-up to last session's bill creating the School Mental Health Task Force. HB 2287 passed, and it actually is a very significant win for school-based mental health. While we saw this session dramatic cuts to school-based mental health supports and educator training requirements, HB 2287 finally allowed to the TEA to release the information necessary to evaluate the existing programs and determine if they're working. Mental Health America is incredibly proud of the work that we've done with Senator Powell and her wonderful staff during the past two sessions. She is kind and warm, but she's not afraid of a fight. She's brave, and she makes you feel brave too. She is absolutely an unflinching advocate for students and understands the significant role that mental health plays in creating safe and supportive communities for children on school campuses. We thank you, Beverly Powell, and look forward to continuing to work with you in the future.
Much for this Mental Health America Legislative Champion Award. This past year has been incredibly difficult for all of us, especially here in Texas. We've dealt with COVID-19, the winter storm Uri, which took down our electric grid, the continuing problems that we have with our electric grid. We've had many hurricanes, and disaster after disaster has tested the mental fortitude of our Texans, and in fact, the mental fortitude of people across America. From 2019 into 2020, we've witnessed a 200% increase in the adults across our country reporting depression or anxiety symptoms. And Texas has the highest rate of depression and anxiety of all the United States averages. During the 87th legislative session, I worked to combat this mental health crisis and to promote the long overdue challenges to our mental health needs in our school systems across the state of Texas. I want to talk to you about a couple of things that we accomplished in my first session in 2019 and that we carried forward in the last legislative session, and that is we created a mental health task force to study the mental health programs that existed in our school districts across the state of Texas. Our first annual report from that revealed that we needed to do a little bit more work in collecting that data. And so we went back into 2021 with an additional bill that was designed to help coordinate the data between the Texas Education Agency and our mental health task force, so that we could define the best mental health programs, and so that we could analyze those programs to see what the impact is being on our academic achievement, school discipline, and our students' well-being. By authorizing that full data coordination, we feel like that our programs will become much more efficient and be more effective in helping our children have the highest levels of well-being. I spent 10 years as a school board trustee before I became a state senator. And one of the responsibilities that I never thought that I would be engaging in as a school board trustee was to attend the funerals of children who had committed suicide. And what I saw over that 10-year period that I was a school board trustee is that not only were our students in middle school and high school experiencing great anxiety, and we were seeing an increased level of suicide attempts and actual suicides in those children, but we were also seeing suicide rates climb among the students that were in elementary school. As my tenure as a school board trustee wound to its end, I found myself attending funerals of children that were younger and younger. So it became a passion of mine, both in my first session and in this last session, to address the mental health needs of our students and to make sure that we were looking hard at suicide rates and making sure that we're providing intervention and programming that helps to prevent suicide in elementary age children. We weren't successful in getting that legislation across the line this last session, but I am more impassioned than ever to make sure that we get it done in the near future. I've told one of my colleagues at the end of our discussion about the bill on childhood suicide, that if we can put our children through active shooter training, that we can for certain make sure that we do mental health interventions, and that we help our teachers to identify students that are in need of special help. So in closing today, I want you to know just how honored I am and how humbled I am in accepting this recognition and this award. I'm incredibly proud of the work that we're doing in the Texas legislature to address the mental health needs of our children. Because of the COVID crisis, because of the Santa Fe mass shooting incident that occurred prior to my election in 2018, we have focused enormous energy and resources toward protecting the mental health of our youngest citizens. I thank you all for the incredible work that you're doing, and look forward to partnering again with you to be a legislative champion for our children's mental health needs. Thanks again so very much.
Hi, my name is Terry White, and I'm the CEO of Mental Health Association Oklahoma. We are proud to nominate House Majority Leader Josh West and Senator Julia Kurt for the Legislative Champion Award for their outstanding work in the field of mental health. The representative and senator are the co-chairs for Oklahoma's first bipartisan and bicameral mental health caucus. The caucus meets monthly during the legislative session to become educated on various mental health issues and discuss solutions for better mental health care and systems here in our state. Representative Josh West is from Grove, Oklahoma, and represents District 5 in the Oklahoma House of Representatives. His interest in mental health stems from his wife being a licensed professional counselor and his own experience in the military. In 2003, Representative West was shot in Iraq and went through his own mental health journey. When he ran for office in 2015, part of his platform was breaking down the stigma of having mental illness so it wouldn't be seen as a weakness, but actually as a strength that people recover from and lead full and productive lives. He's especially passionate about mental health resources for people in rural Oklahoma, for veterans, and for mental health for first responders. For several years, he has run legislation that would allow first responders to receive workers' compensation for mental injuries, regardless of whether they have a physical injury that goes along with it, which is a law that needs to change in our state. I'm grateful for all of the things Representative West has done to elevate the issue of mental health in the House of Representatives here in Oklahoma. Without his leadership, we wouldn't be where we are today. Senator Julia Kurt is from Oklahoma City and represents District 30 in the Oklahoma Senate. Senator Kurt's father served in the military and passed away when she was a young child, which has impacted how she views mental health to this day. Her family was proactive in getting her the mental health services she needed to get through that difficult time. And she decided to run for office in 2018 as a public school parent to make sure all children in Oklahoma had access to the same opportunities and the same mental health supports that she had in order to be successful. She recognized quickly that mental health and substance abuse disorders were barriers to many young people, and how that mental health interacts with all facets of state government, like education and the criminal justice system. Looking toward the future, Senator Kurt wants to ensure that there is parity between mental health and physical health issues, and see that the state implement Medicaid expansion in a way that increases access to behavioral health services for all Oklahomans. I'm proud to call Senator Kurt my friend, and as a fellow mother, I appreciate so much what she's doing for all of our children here in the state and all Oklahomans in need of mental health help. Both Representative West and Senator Kurt are leading our state forward by framing mental health as a topic that should unite us all. Regardless of someone's identity, political affiliation, background, or lived experience, mental health affects every single one of us. And coming out of the pandemic, there has never been a more important time than now to address the issues of mental health in the state of Oklahoma. Representative West and Senator Kurt, thank you for your leadership in creating a space for legislators to have these critical conversations, for helping create the Mental Health Caucus here in the state of Oklahoma. Congratulations on your much well-deserved awards. And we here at Mental Health Association Oklahoma look forward to your continued work in this area and our continued support of that work. Thank you very much.
Hi, I'm State Senator Julia Kurt. I'm from Oklahoma City, and I've been proudly in the legislature since 2018. I'm very, very honored to be recognized with this award this year. We're so proud to work with the Mental Health Association of Oklahoma. This year, my colleague Josh West and I founded the Oklahoma Legislative Mental Health Caucus, and that was a decision to bring together some of the champions and some of the new elected officials together to try to work more strategically to make sure Oklahomans have access to the healthcare they need. This was the first time we've done that, even though there certainly has been legislative action before that. But we're really thankful for the advocates who've gotten us here. Very thankful to the Healthy Minds Policy Initiative for helping us get organized. We really focused on informing ourselves better and trying to understand data-based, evidence-based practices to know who is providing what kind of care, where those gaps are. And, the members who participated, we had a wide variety of legislators. Both parties, from very rural areas to very urban areas. And that's one of the interesting things is that Representative West is from a very rural area in the lake part of our state, hilly lake part, and I'm from the biggest metro area. And we have very different needs, but also many of the same needs. And I think that coming together across the aisle and, Senate and House, so bicameral, we were able to really learn together and start to work on those commonalities that we have to make sure we're serving Oklahomans better. We made great progress this year on telehealth parity, also some progress on transportation and funding for crisis centers across the state. And I know that we made a huge splash in terms of awareness of our colleagues. So those are big steps for us. And I just hope that this is the beginning of us being even more strategic, listening to the field, listening to our constituents' needs, and doing a really good job making sure every Oklahoman has access to the care they need.
Wow. What a great honor this is. It's one of the highlights of my 5 years in office. And I really want to thank Mental Health America Oklahoma for their nomination. And I thank Mental Health America for the presentation. Last summer, Zach Stoikoff with Healthy Minds here in Oklahoma reached out to Senator Kurt and I about starting a mental health caucus. And it was a great year. We had a lot of, obviously it was a bipartisan caucus, bipartisan, bicameral, and it was a success. And, that's the great thing about when you're working with, when you're working on mental health legislation, it's not a partisan issue. I think everybody at this point has experienced some kind of, mental trauma or knows a family member that has, especially over the, last year and a half with COVID, and especially with our youth. And so I'm definitely humbled, very grateful. My wife is a therapist and an LPC by profession, and she's a veteran, works for one of our great community mental health providers here in Oklahoma. And so it's definitely a huge topic of conversation at my dinner table. And, I've done everything I can over the last 5 years to kind of do away with that stigma that's always been associated with mental health. And it's a lot better than it was. I'm a veteran. I was shot in Iraq in 2003 and in Karbala, Iraq. And so shot in my legs and my stomach, had a traumatic brain injury. And I went through some really tough times, but I used that story as motivation. I mean, there were times that I truly didn't care if I lived or died. And if I didn't have, my faith, if I didn't have a family that supported me and a wife, and a good therapist, I wouldn't be here. I have no doubt I wouldn't be here. And so, every day I wake up and I've got scars and skin grafts on my legs and my stomach, and I use that as motivation. I was able to participate in with Secretary Wilkie when he was the Secretary of Veterans Affairs. I was able to participate in an executive order signing when they were implementing the Prevents program to get that money down to your local mental health providers. And so I really got to meet several people throughout the United States that veterans have been working on this, and it's a great part of the job. I look at this as a Republican. When I present mental health bills, I say, this is a pro-life bill. This is going to make someone's life better, and that's our job. And so, I know that you all have been working on this use for a long time. My personal story, like I said, I will never stop, pushing for mental health treatment, especially in rural Oklahoma. We deal with deal with obstacles that they don't in urban areas with just the resources available. So this is I'm kind of at a loss of words, but it's a huge honor. And I want to thank you for the work that you all do. And thank you again, Mental Health America of Oklahoma, for nominating me. And I am so honored. Thank you so much.
You can see why this is our favorite part of the program. We really are honored to say thank you to the mental health champions who are working in legislatures all across the country. So thank you to this group of legislators, the ones that we said thank you to last week, and we're really glad that they're working as hard as they are, and we appreciate them every day. It touches us greatly that they too fight in the open, as did Clifford Beers, and share their own stories. We're going to dive deep now into the heart of today's meeting, from deflection to prevention. And this meeting really is a continuation of the first part that we did last week, from diversion to deflection. And we're concentrating today on youth and young adults. And this is important because youth with mental health issues, with mental health conditions, they have the highest dropout rates of high school. They have the highest dropout rates of any other group. And they're also expelled at much higher rates. And what happens then is we can see it in the fact that 64% of men and 66% of women in local jails have a behavioral health condition. And 80% of those men and women who've dropped out of high school who are in local jails and prisons, they have dropped out of school. So we have lots of data about that, and we know that it takes a long time for people to get the help that they need if it's not recognized. So I'm going to welcome my colleague, Theresa Nguyen, who is going to show the data that MHA has and we have collected over the past few years that really shows the ongoing need and the urgency since the pandemic to really focus our attention on youth. Theresa?
Hi, everyone. Welcome to the RPC. My name is Theresa Nguyen. I am the Chief Program Officer at Mental Health America. I am so happy to kick you off today on discussing the importance of America's youth and how we can start to serve them and some of the data that we've had. Like so many at our MHA office, the fight to work for prevention and early intervention for youth is a personal one. It isn't new news that historical data on research indicates that it takes, up to 10 to 15 years for young people who first identify the warning signs of depression or anxiety to wait 10 to 15 years before getting treatment for the first time. And same, 2 years for psychosis. For many of us, this tracks right with our personal stories. 2020 was just a difficult year for many people, and I do recall reflecting in 2020 in therapy and with families and friends, just being in my 40s and looking back at how young I was when I was first struggling with mental health problems, and realizing that I was just 11 years old. And what that means when you're just 11 years old or in the 6th grade, you forget how little that person is. And at that time, problems were probably existing for a while, because I remember at 11, it was the first time that I actually started struggling with thoughts of suicide and self-harm. And, sometimes when we sit in this data space, it's hard to wrap our heads around what it means for the youth who are struggling with mental health problems in their homes during COVID, sitting in isolation. And so much of this is important as we head forward into the future to advocate for a better place where our young people can get access to mental health care. What I will be sharing with you today is the data that we have been tracking here at MHA National. If you do not know, MHA National has been fighting for ubiquitous mental health screening in schools for ever, maybe as long as since 1909 when we were founded. And so much of why this is important is because this is the first time someone identifies that they have a mental health condition. As part of the effort to fight for ubiquitous mental health screens, MHA started the MHA screening program, where we decided to provide mental health screenings available online for free for anyone who chose to do so. Today, this includes for schools who are looking to increase mental health screenings in school. And I'm proud to say that coming into 2021, we will hit a benchmark of having served or supported nearly 10 million individuals who came online to take a mental health screen. Here are available 10 screens that we have provided to people, and I'm going to share with you a little bit of data, both from MHA screening and from some of the national numbers that we're tracking at national. So in 2020, there was an incredible increase in both the number and the rates of mental health challenges. I think the numbers were quite striking for our staff. You know, historically between 2015 and 2019, we saw about 1 million users coming in to take a mental health screen every year. And in 2020, that number jumped to 2.6 million. And then we started tracking our 2021 numbers, and it looked like that increase continued. And so by the end of 2020, we're slated to serve about 5 million individuals for the year. More surprising than the increase in numbers that comes in is actually the change in the rates of severity. These are numbers that don't typically change. You can see, for example, in the rates of suicidal ideation from 2016 to 2020, that the rate of individuals who report thinking about suicide more than half a day or nearly every day for the past 2 weeks has been pretty static. This is also true for the severity of the mental health challenge that any person is screening for. That means that the number or the percentage of youth who are struggling with psychosis, bipolar disorder, or depression has remained fairly static through the years until 2020, where we saw that rate of severity increase from 71% to 77% across the board for all screens. What this means is that the stress from the COVID pandemic is absolutely having a profound impact on the mental health of our youth. This is not surprising given what we know that we all went through. As a part of that effort, the policy team has released a report called Addressing the Youth Mental Health Crisis, the Urgent Need for More Education, Services, and Supports. And this is so profoundly important because we understand, as many of us do, that you can only get to people who are struggling with a mental health condition if you reach them where they are at. And for our youth, this is the case that they are in schools, right? Especially if we're going to start to understand how to reach people from an equity lens and making sure that we capture people who are most likely to fall through the cracks. Along with following MHA screening data, historically, MHA has also started tracking trends of prevalence rates of mental health conditions across the states and the country since 2009. This data is provided to us through SAMHSA on the National Survey on Drug Use and Health, for any of those people who are interested. This data is done using a national survey methodology. This means that these numbers are generalizable across the country. And what you see is that even across time, the rates of depression among our young people has increased fairly steadily. At MHA, we've also been tracking our trends among various populations who are struggling with mental conditions among underserved populations. Consistent with MHA screening data, the SAMHSA data identifies that individuals or youth who identify as having 2 or more races consistently show the poorest outcomes. This is a trend that we've been very interested in to understand the intersectionality of race and social determinants of health that we know impact poor outcomes and good outcomes for our youth across the country. Let's see here. Next slide. The way treatment access occurs is also disparate. certainly as part of ensuring that youth get access where they are and when they are, this means not only evaluating, making sure that youth are screened in schools, but understanding how youth are then getting care or access to care in a streamlined way in their community or in schools, and how that is available to our youth. And you can see that the percentage of youth who say or have been screened to have a past year major depressive episode who received treatment was still very low. As a country, we should be doing better, right? And this is especially true for youth of color. Black youth across the country report that only 25 to 35% of them who have a mood disorder or a depressive episode are receiving treatment. And for Latino youth, this rate is 35% across the board. And even for our white youth, the number of youth who receive treatment is only 40 to 50%. That means 1 in every 2 youth who is struggling with a depressive episode is not actually receiving our care. And so the policy requirements that have to be addressed include what it means to look at children, evaluate and screen them in schools, and then to also identify what treatment options are available, especially in our communities that do not have adequate access to care. I think of interesting note, if you haven't seen some of our data from our MHA screening data, is that when you ask individuals what they're going to do after a mental health screen, our Black communities are actually not the ones who are saying that they're the least likely to do something. Our Black screeners say they want immediate treatment and they want care. And this is so important for MHA because it really signaled this idea that we needed to stop talking about stigma or fear of discrimination as a factor for certain communities, that in fact there were communities who were saying that they wanted treatment. And part of the narrative that was so important is about whether or not culturally responsive care exists, right? Do school-based services exist? And the way this plays out back to a personal level is that when we ask our youth what they're saying, they have insight. They know that they are disconnected. They know that something is not quite right. They know that they don't have the help that they need. And they know that they don't know where to go next. And they're reaching out to people, they're reaching out to the internet, they're reaching out to their friends and hopefully to a trusted loved one about something that might be going on. And it really is our responsibility to create a system that helps them not fall through the cracks and can get them on their way towards mental health recovery sooner than later. And what's wonderful about this is that we know that treatment in schools work. The research on trauma, creating trauma-informed schools is effective, not just in treating and helping to mitigate the cascading consequences of mental illness across the lifespan. It also works to actually improve positive outcomes. Our kids stay on track, they graduate from school, and they go on to keep their lives. And this is why we do what we do. So today I'm so excited to have you join us as we do the most important part of today and talk about solutions and talk about what we need to do in our future to make this right for our youth. Thank you for joining us.
Thank you, Theresa. We are indeed going to hear about solutions, and we're about to move into a panel that will be moderated by my colleague, Caren Howard, and you'll hear from Mary Giliberti, Sydney Daniello, Ethan Burrell, and they're going to have a conversation about the amazing report, the urgent need for more education, services, and supports.
Hi, everyone. I'm Caren Howard, the moderator of this next session entitled MHA Report Findings, the Urgent Need for More Education, Services, and Supports. We really appreciate you all tuning in and continuing to participate in this policy meeting. And we are especially proud of the work of this next panel and the authors that are joining us. We have with us today MHA's Executive Vice President of Public Policy, Mary Giliberti, MHA's Program Associate, Sydney Daniello, and MHA's Policy Intern, Ethan Burrell, who is with us this summer and has been a great contributor to the report, especially thanks to the Jeanette K. Watson Fellowship, which is helping to support his internship with MHA this summer. As you all know, lived experience is really at the heart of all that Mental Health America does. And we really thought that producing this report was important for policymakers, decision makers, individuals and families, as well as organizations, because our MHA screening data from across the country is showing clear trends in our youth. And the data, as you heard from Theresa earlier, is warranting a response. So let's hear from Mary, Sid, and Ethan about the report that was released on July 20th and how we can set up a framework for going forward to meet young people where they are in schools.
So the report is the youth mental health crisis, the urgent need for more education services and supports. And addressing the youth mental health crisis is the exact reason why we did the report. And the report focuses quite a bit on state initiatives because they are the laboratory for change, as we all know. And so we can look at what's working. And we hope that the folks reading this report will be able to use this information to move forward in their own states and also nationally. We'll talk about those recommendations. So who is this information for? Who will we be targeting with this report? Target audience includes, of course, state policymakers, because we're looking at state policies, advocates, folks out there who want to make a change, youth, and you're going to be hearing how youth leaders have pushed so many of these policies forward. Their voice has made an incredible difference. So they are certainly an important audience for this report. Families, administrators, mental health professionals, and educators. In several states, educators have really pushed these policies forward because they see the difference in the school system when we have education and treatment and services.
So as we've heard so far, the youth mental health trends are troubling and access to care is limited. Rates of young people experiencing depression doubled over the last decade. And as you can see, the percentage of youth who report experiencing a past year major depressive episode has steadily risen over the last 10 years since 2009. And as you've already heard from our colleague Theresa, COVID-19 has only worsened that. It's thrown fuel on the fire and exacerbated these alarming trends. So the report we put out on July 20th addresses some of the key ways that we can use school-based mental health policy to meet young people where they are and address these issues. The report highlights states such as New York, Virginia, Oregon, and other states that have been leaders in establishing legislation aimed at improving youth mental health in schools. Mental health education was one of the topics that we covered most extensively in the report, as it's proven to be an effective intervention for improving youth mental health. States that mandate more mental health policies have significantly lower adolescent and youth adult suicide and substance abuse rates. State mandated school-based mental health centers, social emotional curriculum, and school professional development and suicide prevention are all associated with much lower adolescent and youth suicide and substance abuse rates. So some of our recommendations for this topic area include building on what exists and being vigilant with implementation. So some states like New York and Virginia have statutes, while others have regulations or other structures in place that definitely need to be built on and improved. The report includes several state-by-state charts where you can see where your state is, see what exists in the state already, and see what you can add to what's already there. New York is an excellent example of a state that was able to both build onto existing policy structures and create a resource center to help with the timely and successful implementation of new legislation in the state. A 2-word addition to existing legislation regarding health education was what allowed the expansion of K-12 health education requirements in the state to include instruction on mental health. So you can see that legislation here, and that 2-word change was one of the most significant bills that we focused on in our report. So in 2018, our affiliate, the Mental Health Association in New York State, was able to secure legislative funding to create a school mental health resource and training center to help schools successfully implement the new mental health law, the new mental health education law. Resources from the center were created and made available to all New York State public schools and private schools at no cost. The center and the sources they provided played an important role in the effective implementation of the law by helping schools to develop their mental health education curricula in time for the fall semester. Interest from the school communities, including families and school personnel, as well as teachers and other community members, has been very high so far, with over 88% of school communities contacting the Resource Center.
And now we're going to talk about the second section of the report, which was about school-based services. And this was a very extensive section of the report with lots of recommendations. The slides will be available to you after, and of course the report itself has all these examples detailed. So with respect to Medicaid, we often say no money, no mission, right? So you need that sustainable financing. And earlier, CMS, the Centers for Medicaid and Medicare Services, said that you can use Medicaid beyond the services that are in what we know as an IEP, an individualized education plan. Those plans are only for students with some of the most significant disabilities, including in the mental health area. So lots of students get help who don't have that IEP. And CMS said you can use Medicaid beyond those plans. And only 14 states to date have taken advantage of that. And you can see that on the chart. And so it's really important that advocates in other states get that financing in place. And we detail in the report the story of Michigan, and we cite to some additional fact sheets done by other organizations that you can use to really understand and move that forward in your own state. Telehealth, we all know during COVID-19, massive use of telehealth, right? And states have chosen to make it really clear that Medicaid will pay for telehealth in schools, but only about half the states have done that. And then some states have really gone above and beyond and really well developed their telehealth mental health program. And Texas is a wonderful example of that. They provide extensive mental health services for students across the state, reaching areas that don't have the needed providers and getting to students quickly and connecting them up with local resources. Ratios. So we know that mental health services can get provided in the school by school-based mental health providers and by community providers. The ratio issue is school-based mental health professionals. How many do we have per how many students? It's been proven that states that have ratios in statute do better at having more mental health professionals per student, and that makes a big difference. What we found is our youth talked about how they had found that their counselors weren't always available to them because they were so busy doing career counseling, college counseling, administrative work, and not helping them with their mental health issues. So ratios are very important. We highlight a few states there that have been working on that issue. Services at the schools by community mental health providers. And this is one of the most impactful policy recommendations that we have in our report. This is how states have brought community providers right to the school site, so students don't experience all those barriers. And this has been particularly helpful in reaching students of color, because you're eliminating all those barriers to care, and they are, as a group, more likely to only receive their services at school. So our advocacy recommendations here are twofold. First, to seek sustainable funding for community mental health providers, funding that they can continue to get, not just one-time grant funding, and design programs that increase access to mental health care and address inequity.
So the next section we'll talk about is excused absences and youth empowerment. So young people care about the excused absences for mental health. Just like a regular sick physical day, so you have a fever, it's also imperative that students are allowed to take a mental health sick day. Such as Oregon HB 1291, a group of students such as Haley Hardcastle and Derek Evans, they actually advocated for students to get a mental health sick day within their state of Oregon. It's imperative that we also empower youth leadership and involvement, as we have to empower, really, showcase the voices of all young people, make sure they can be heard throughout the United States. So it's imperative that the legislators, advocacy groups really try to incorporate the voices of young people, because at the end of the day, they are the target group that we're looking for to really allow them to have a good mental health in order to pursue their education in the future.
So resources in the report. Let's talk about what you can use that we put together there. There are state charts. So every topic that we've discussed today, there are charts that show you your state and what's going on in the state. So you can take a look, see what you have and what you might still need. Fact sheets and an infographic to make the case to policymakers. We've talked a lot about all the data, but this is a clear, crisp way that you can just hand these one-pagers off to legislators. It would be great if you can add some facts from your own local community or your state to supplement what we've provided on a national basis. And then the playbook. The playbook is a really simple way of looking at what happened in New York, what the things that they did to overcome resistance. And it's a quick way to get the information that you can share with other advocates and talk through the playbook and how you're going to approach this in your state. And then, of course, the full report, which has a lot of detailed information, much more examples and details and facts than we could possibly present today. So we look forward to helping anyone out there who's working on these issues. We're here to support our affiliates and others who are working to advance youth mental health in schools. And we hope that you will make good use of all of these resources and materials.
So thank you so much for that wonderful overview of the school-based mental health services, supports, and education report, Mary, Sid, and Ethan. I'd love to have a conversation with you, and feel free to hop in where you feel most ready to answer, but we did have a list of prepared questions, and we actually have 15 to 20 minutes to discuss, so we can go into a little bit of detail. I'll start with you, Sid, and then open it up. Sydney, the report highlights a lot of screening data that you covered just now, and that Theresa covered as well in her earlier presentation, including the steady increases in the reporting of and severity of anxiety, depression, and suicidality in youth, as well as the disparities that are apparent between Black and Hispanic or Latinx youth in receiving treatment and white youth receiving treatment. Appendix A and B of the report, which are printable resources that you guys made available to advocates and policymakers, show even more trends and particular facts in MHA screening data. Are there particular trends in this screening data that you'd like to highlight and shine a light on for today's policymakers and school district leaders who are tuning in?
Well, I think there are a couple of things that are really important to understand that are highlighted in some of the data in those infographics and fact sheets that you mentioned. The first thing is the severity of the issue. So one fact that really stuck out to me that sort of highlights how severe this is that of those ages 11 to 17 who took one of MHA's screens in 2020, 51% of them reported having thoughts of suicide or self-harm more than half or nearly every day of the previous 2 weeks from when they took the screen. And that amounted in the whole year to nearly 160,000 young people. So I just want to reiterate, 160,000 young people felt suicidal or like they were considering self-harm and that was just in the previous 2 weeks. So that just highlights how severe this is and how young this issue is affecting people. Another thing that's really important to acknowledge with regard to this data is that youth mental health has been getting worse over the last decade. And I know I already said that, but it's important to understand that COVID-19 has definitely exacerbated those issues, but they were troubling trends before, even before a worldwide pandemic. Youth were struggling. And so it's even more important now that COVID-19 has exacerbated those issues to address them, but these aren't things that just popped up suddenly. And then for policymakers and agency leaders, one thing that we highlighted in some of the resources in the report is that only 43% of all young people with a past year major depressive episode received any mental health treatment at all, with even lower percentages, like around 33% for both Black and Latinx youth. And that's a really low percentage of people who need help who are not getting help. And among young people who do receive mental health services, nearly 75% of them receive them at school. So that's why we created this report, is to meet young people where they are in schools, because it's one of the most efficient and equitable ways to meet the mental health needs of the most students, especially those who are falling through the cracks. So Black and Latinx youth, LGBTQ youth, all of these groups have had really troubling trends in the past, and with COVID-19, it's gotten much, much worse. So to have this report, to have these resources, to try to meet these groups of people where they are, and to try to make sure that we can address the mental health needs of all students in schools is really important, and that's why we made it.
Thank you so much, Sid. We know that suicide is the one of the leading killers of young people ages 10 to 24. We know that young Black kids are having the highest increases in the rate of suicide attempts, and that there's additional pressures that perhaps older generations may not understand, in addition to kind of academic performance and, fitting in and having some social pressures. There's also this, idea that they have to meet all of these benchmarks and be prepared to enter the real world upon graduation, in addition to taking care of family or having caregiving responsibilities. I think young people are feeling especially distressed during this time, and there are ways that schools can meet them. So I think the recommendations in the report to facilitate a state response and hopefully a national strategy is much needed. So thank you. To Mary, research shows that a student's mental health and emotional state due to past trauma can impact academic performance. And the report urges legislators and school district leaders to really transform their thinking about framing educational equity as health equity, or framing health equity as part of educational equity. This was discussed at many of the advisory board committee member meetings that we held to inform the report. Would you discuss any specific recommendations or ideas that you highlighted in the report to help school districts overcome academic underperformance by including a health kind of focus with that?
I think that as we've been talking about, COVID really has impacted students in new ways. And for students of color, not only do we see trauma, like you said, Caren, but also grief. It disproportionately impacted those communities. So we are learning through policymaking and through the data that is being collected after the policies that there is a link between mental flourishing and academic performance, right? That probably seems a bit obvious, but it's not always thought about that way. A lot of times there's just such a focus on those academics, not realizing that if you leave behind the mental health and the health, you're not going to get that academic achievement that you're looking for as educators. So what we found is policies that focus on mental health education, focus on mental health services in schools, can make a difference with respect to access for students, but also with respect to their academic performance. So the research on social emotional learning and mental health education shows an impact on academics. And likewise, bringing the services to the schools also showed in Kansas, where they did a pilot project, they got lots of really strong outcomes, not only in academics, in attendance, and also in how students and families felt about the services. They were really happy to have those services right at the school. And that just emphasizes why it's really important to talk to youth and their families as we evaluate the programs and policies that we're putting forth.
Thank you so much. And it's really helpful that you identified the state of Kansas's program, and that throughout the report you have the appendices C, D, and F, I believe, or C, E, and F, which are state charts that any advocate, family member, or legislator can point to and say, okay, what's in place now? And that's really a theme of the report. Look at what's in place already before you start building a framework for going forward to meet the mental health needs of students through schools. So I think you all have done just a really incredible job of making this report useful for every state, regardless of where a person might reside, as well as making it really comprehensive to inform possibly a national strategy that our, congressional or administrative agency leaders can use to move forward as they're targeting ways to support states. For Ethan and Sid, if you want to hop in, the report highlights the role of students in the policymaking process, and you guys touched on this in your PowerPoint. The report includes video remarks of 3 just incredible young adults: Melanie Zhao of Colorado, Angela Wallace of Massachusetts, and Ben Ballman of Maryland, all who are responsible for catalyzation of tremendous change in their school districts and across their states. Their advocacy led to increased funding for school-based mental health services and mental health professionals. It led to improved school mental health professional to student ratios, as well as a prioritization of healing and trauma-informed programs for students on campus following a crisis or following a loss to suicide. Mary, you really hit on the point that there is a grief process that takes place, following loss, whether it's human loss or other losses that have been experienced during COVID-19. Can you, Ethan, just describe how the report encourages school districts to empower student leadership in the decision-making process, whether it's at the school education board level, the community level, or at the state level?
Yes, of course. I think you actually hit it right on the nail on the head when you mentioned that basically the report consists of a lot of data in terms that community boards, local communities, state levels, legislators can look at the report and see all this data and see that youth have actually been like the pioneers to advocate for this type of mental health bills. Melanie, Angela, and Ben, they really put all this work in, and if you see how they really got all these outcomes, the positive results that really resulted in better school mental health. I would also say that it's also imperative that these school districts also look inside themselves and look at, is there anything that can tweak? Is there anything that can fix with their own mental health structure, see how they can empower their students? So really surveying students. Luckily, I remember Ben talking about it. He said he even surveyed his group of students in his district to see how they felt about their mental health and how the school was going and how the schools could support them. So it's really, I really believe that if the school districts really support students, then they'll feel like they can actually make change. So yeah.
I think you're 100% right about that. Sydney, you were going to step in too.
Yeah, I was just thinking that I could add that something that Ethan said was that this report has both a lot of data and useful resources for young people to use, and also some success stories, which I think is really helpful to hear about, because sometimes young people feel like, they really want to make change, but they've never seen anybody their age or who looks like them do it. So being able to see those success stories and see the incredible work that's been done by peers is, I think, something that helps build the confidence for young people to continue advocating. And I say this over and over again, but if you want to help young people and you want to know how you can help young people, the best thing that you can do is ask them. And so we definitely tried to do that with this report, but it's really important to keep doing. And that means like building in ways into your school district or at the like local legislative level and beyond, as well as like within organizations that advocate for this kind of thing, build in ways to hear from as many young people as possible and as many types of young people as possible, so that you're able to get a representative understanding of who you're trying to empower and who you're trying to help and how you can best help them. So yeah, I think between me and Ethan, we have really can't say enough about how important it is to empower youth to make these kinds of changes. And hopefully this report can help with that and help encourage other people to help with that.
Yeah, Sid, I think you and Ethan hit the nail on the head when you said that just ask them. You know, when you're talking about helping a certain particular group of people, I think MHA was actually founded on the belief that, you know, the lived experience and the person that's experiencing a mental health condition must be empowered to be involved in their treatment, in their treatment plan going forward. And other people who have similar experiences can also kind of pitch in. And that's where the importance of peer support and peer work really comes into play. So nothing about us without us. Mary, I wanted to turn it over to you as we kind of circle back a bit towards equity. Studies show that access to treatment for Latinx and other students of color increases significantly when services are delivered through schools. The report recommends the inclusion of culturally and linguistically appropriate services, whether provided through community partnerships with private clinics, or telehealth or in-person services, or through school-based health centers. Decreasing the ratio of students to professionals is another way to improve access and help students receive treatment in schools. Why is it critical to access health services through school districts? And let's start there. Why is it critical for students to access? And you did kind of answer this already, but if you have any other input, let us know.
Well, Caren, I think it's so important because it goes back to the statistics that Sid cited earlier. When you think about the idea that 1 in 3 students of color are getting services that they need, that is just unacceptable. And so by providing services at school, we knock down those barriers. And anybody out there who's tried to make an appointment for mental health knows about the barriers, right? You got a transportation, you got to make that appointment, you got to find somebody available. It's a lot and it's very difficult. So bringing the services to the schools really decreases those barriers to care and allows somebody to receive it in a community setting, which is also easier for people. There is a lot of concern and sometimes stigma still around mental health, and particularly in communities of color, and concern about, identifying as someone who has a mental health condition. And so having those services be right there at school really helps make everybody understand that this is part of the community, it's part of life. People have all kinds of different conditions, and we need to get help when we're not feeling well. And that's the message that we want to send. And I think school-based mental health helps send that message and reach students who otherwise would not have access to services that they need.
I think you're 100% correct. And, this question that I have for you goes a little bit beyond the scope of the report, but I think might be important to some of the advocates that might be using our resources. What advice do you have for parents or school administrators concerned about labeling more students as having a mental health condition or emotional disturbance or other disability recognized under the Individuals with Disabilities Education Act, who might qualify for services through school?
Well, I think that's part of why we recommend mental health education. I think the education part is really important. So everybody understands that these conditions are just like any other healthcare condition. And having that conversation with families, with students is really important. And I think that's why we also call for a comprehensive approach. You can't just educate the students. They live in families. The families have to understand when a student brings something forward, how to respond to that. You have to educate teachers and administrators, school bus folks. And I think that we pointed out the Technical Assistance Center that's operated by our New York affiliate, and you'll hear more about their work. But that allows for training and discussion of everybody who's going to touch that student's life. And I think that's really important if you're going to address these concerns and help everybody understand. These are health conditions, just like any other health condition, and we want people to flourish. So you have to get help when you're not feeling well so you can do your best work, both at school and at home.
And I wanted to close out with a final question that relates to just during the time that we live in, COVID-19. There really is an opportunity that we have, with all of the suffering and loss and trauma that we've experienced, the isolation, the really, hard times that families have been experiencing over the last year and a half. There also is an opportunity to draw down federal funding that's way at higher levels than we've seen in the past. Some of that is one-time funding, and some of it will be ongoing for years to come. What advice do you have for states and school districts to, ensure this funding is used for meeting the mental health needs of students in schools and for ensuring that there's a kind of a structure in place going forward?
Well, I will just reiterate what Sid said earlier about listening to your youth, about what they need and what they want to see that those resources used for. Melanie Zhao spoke about how she stood up before her school board and talked about how they needed to allocate resources that were coming into that district to more mental health professionals in the schools. So I think it's really important to listen to youth and also to look at some of the resources are not targeted to anything in particular. They're for the schools to really think about where the needs are. We've talked about this data. We've talked about how students are feeling. Need to make sure that where the money is following where students think the need is. And that often is mental health.
Well, we know that there's increased need. We know that there is some increased resources coming down from the federal level. And we know that school districts are hoping to meet youth where they are in a comprehensive way. And we ask, I think through this panel, that policymakers and decision makers really support those school districts. Educator mental health, student mental health, should all be a part of that comprehensive framework, in addition to education, as well as services and supports, including excused absences. Well, I think that wraps up our time here today. It's been really a pleasure to speak with you, Mary, Sydney, and Ethan. Thank you for making the time. We will now turn it over to our next panel. We'll be joined by Dr. Art McCoy, former superintendent of Jennings School District, as well as Dr. Bernadilla Johnson, former superintendent of the Minneapolis School District. These two former superintendents will have a conversation with our MHA board member, Amy Kennedy from the Kennedy Forum, who is a former educator as well. And they'll discuss how they really transformed and created great outcomes for their majority Black school districts and ensured policy change that led to increased high school graduation rates, increased academic performance, and decreased rates of dropout and missed days in schools. These are all things that we're all, all school districts are working towards. So I think there's something to learn.
Thank you so much for joining us today. I'm Amy Kennedy, and I have a fantastic panel for a discussion with Mental Health America's Regional Policy Council meeting on deflection to prevention, a focus on youth. My own experience as a public school teacher and as a parent really builds my interest in what we're going to discuss today, because we know even before the pandemic, mental health was at epic levels in our schools, and yet we're so poorly trained. Often teachers like myself feel at a loss at how we can address this for our students, even though it's the most critical need. And yet today we're joined by Dr. Art McCoy, former superintendent of Jennings, Missouri School District and St. Louis University Distinguished Fellow. Most recently, under Dr. Art McCoy's leadership in the 2018-2019 school year, Jennings made Missouri history as the only performing at the accredited with distinction range on the Missouri Accreditation Annual Performance Report, regardless of over 90% minority and 90% of students on free and reduced meals. That is an incredible record and achievement. And we're also joined by Dr. Bernadette Johnson, former superintendent of Minneapolis, Minnesota School District, and current assistant professor, Department of Educational Leadership at Minnesota State University. So lots of things to discuss today. And I'm so happy to have you both on. I'd love for you to just tell us a little bit more about the demographics of your school district, Dr. McCoy, and kind of how we got here.
Thank you so much. It's a pleasure to be with you and all of our guests and leaders. So my school district has literally 98% African-American population, 1% Hispanic, 1% Caucasian, and we have 100% of students on free meals. And ultimately, don't let that data define us. We were a promise zone, but we ultimately had 100% graduation rates for 2 years in a row and 97% for 4 years. So I was there for 6 years, and we've had 100% career and college placement of our students. Frankly, as a superintendent, I use the promise zone data of dropout rates, birth pregnancy rates of youth and unemployment as my ruler for success to end that. And so we are a success zone as opposed to a promise zone now because of the success of our students and the hard work of our staff. We're a small school district, so this is the smallest district that I've led. This district has 3,000 students from pre-K through 12. My former district in Ferguson, Missouri, Ferguson, Florissant, 14,000 students, 80% minority, and the district before that, 22,000 students. But the key is mental health education and trauma-informed practices. And we instilled that throughout all of our schools and in the region, and it made a significant difference. So I look forward to talking more about those practices.
Thank you. That's really interesting to talk about the size and the scale of the way you're able to implement that. So I'll look forward to hearing more. Dr. Johnson, could you tell us a little bit about the demographics of where you work?
Yes, I'm the former superintendent of Minneapolis Public Schools. And when I was in Minneapolis, we had about 36,000 students. 70% of those students were students of color, and about a third are ELs. And then we had a really large, highly homeless and highly mobile population, as well as a large percentage of our students being referred to special ed. I would say that we had the distinction, not the honor, of having one of the largest achievement gaps, not only in Minnesota, but probably across this country for a city like Minneapolis that has the wealth that it has. Though we've started to see some changes in trajectory of outcomes for students based on some of the policies and practices that we put in place, mostly around changing our behavior practices, doing MOUs with our police SROs, as well as working with NAMI to look at our mental health services and work with the community. And so I also established the Office of Black Male Student Achievement, because for every indicator of success, our Black boys were at the bottom. For every indicator of failure, they were at the top. And so I can't say that we did anything more significantly in changing graduation rates, but we did do that for that group of students. And this was like 5 years ago, but what I feel really blessed about is being able still to talk about the great work. And because it was good work, they're still continuing the mental health model in Minneapolis. And I have the opportunity to testify at the legislature quite frequently about this work, and I'm very proud of it. Thank you for having me. I'm sorry, I forgot to say everyone. Thank you for having me. I'm really pleased to be here, especially with Dr. McCoy and yourself, to talk about this very critical issue for our students' well-being.
Thank you, Dr. Johnson. You know, if they're still asking you to testify, that
Absolutely.
must mean Two things. One, that what you did was really phenomenal work. And two, that we must still have a long way to go because they need to hear more about it. And so that's really why we're here today. We want to talk about why schools are the place that we can make real progress and a great place to address our students' mental health needs, not only for the students themselves, but for the whole family. Why this works and why the moment is now to really be talking about this as we're heading back in September. What kind of transformational changes could happen that have already been modeled in your districts and that we can take to scale around the country? I would love to hear a little bit from each of you about what it was like when you first came aboard. I know my experience going into my first teaching assignment was that I was completely unprepared. And so as a new teacher, I was presented with all different students with challenging behaviors and diagnoses and issues that they brought to the classroom. And yet I was a little bit intimidated to ask for help. I didn't want that to be a reflection on my teaching. I didn't want it to look like I couldn't handle the classroom. And so, you know, I struggled to find strategies that might work, but they weren't necessarily evidence-based. What was it like when you came on board, and was your school already moving in this direction towards mental health education, or did you have to bring it from scratch? Maybe Dr. McCoy, do you want to tell us where you started?
Sure. Let's start with my previous district. So in Jennings in 2016. So actually, I was the youngest superintendent in the state of a school district over 2,000 students when I was at Ferguson, Florissant at 14,000 students. And Michael Brown Jr. was my freshman student who the world for having been murdered and passed away and laid on the ground for 4 hours until he was, taken, and the community saw it in March. And so right as that occurred, I was in California as a superintendent in residence in Irvine. However, I was called to come back because of the mental health work that I started in Ferguson before Michael Brown's death. I got called to come back, and I came right next to Ferguson, Florissant, which is Jennings School District, which serves part of South Ferguson, all of Jennings, and a part of the city. And frankly, so having had experience with it in the past, having started a school-based health clinic in Ferguson, Florissant, having had physicians and therapists in that setting at McClure High School, that then led to me coming to Jennings and literally having every school have that same vision: 2 therapists, a school-based clinic at the elementary and high schools, the only district with the dentistry, with mental health, and then eventually therapists dedicated for teachers due to secondary trauma. So when we began in 2016, the district knew that there was a need for this. I often say this, students of poverty are suffering from many epidemics before there was a pandemic. The pandemic just made everyone aware that when something happens, we all need to work together to create a system to help us get through it. But pandemics occur like every 2 hours. One Black male expires. More than one Black male expires every 2 hours. That's an epidemic. That epidemic requires an infrastructure that has what I call centers for healing engagement. Because often this is a lot of either Black on Black incidences of homicide, or in the case of Michael Brown, police authority against African-American males and African-Americans. So in either case, you have to have de-escalation centers. You have to be a center for de-escalation and a center for healing engagement, a center for guided imagery, meditation, yoga. And so when I began those practices, even voluntarily for the staff in country club settings on happy hours with peace circles, they fell in love with it. And they said, we need more. We had a needs assessment occur to see what needs were in the homes of our children, but also within our staff, from do I not want to teach because my dog died, to I just experienced a divorce and I just don't have the substance within me. You can't lead on empty. And so you ultimately have to help fill people's cups with the appropriate life coaching to navigate life's waters. And so that was the beginning of our journey. How do you fill your cup with life coaches throughout life's journey?
Oh, I love that. That's the kind of support teachers absolutely need. That if we're going to model it, we need to be experiencing it. And I couldn't agree more. And it sounds like a lot of trauma for the staff as well as the students, of course. And I think it's really interesting that you started with mental health centers, not only at the high school, where I think a lot of us traditionally would think about this, but the elementary as well, because we know getting the kids the right foundation, learning those coping skills early is going to be key. Dr. Johnson, what was it like when you came on board?
Chaotic, people not paying attention to the data and the information that was obviously there. And I would also sometimes say it was a lack of curiosity, a lack of trying to understand what was the basis for what we were observing. And I would say that, and I also hesitate, and I'm very careful about when I talk about the mental health model we put in place in Minneapolis. It wasn't to suggest that all kids were mentally ill. It was to suggest that our kids need strategies, de-escalation. They need to know how to self-regulate and do things that were necessary for them to be successful in school, as well as to acknowledge the fact that some of the episodic things that Dr. McCoy talked about were taking place within the school. So what are the antecedent behaviors? What are the things that you're doing to trigger these behaviors from students, especially when you see it happening in one classroom and not in another classroom? So I knew I needed to do something systemic. And my strategy was to start with I started with my K-8 schools, my kindergarten, my pre-K through 8th grade schools. And we looked for mental health therapists within the community. We wanted them to be people that look like the students that they served. And quite frankly, we didn't always have a lot of those folks available. But what it did is to push those organizations to start hiring and more diverse therapists to come into the schools. And what it provided is a way for the therapists to be more intentional, working with teachers on strategies for the entire classroom, not just with specific students. And actually, I feel like I know, but I don't have any data to suggest this. This is why data collecting is really important. To talk about what Dr. McCoy talked about, the fact that matters, I know some teachers will pull a therapist aside, like, how can I get this help for me? We didn't provide that, but we certainly wanted folks to take advantage of our EAP program. EAP, I think that's the name of employee assistance program that existed for them. But I would say that what was most disturbing to me is when a student was having an episodic behavior. And the first thing to do was to call the police, because they could take them to like a day treatment, take them to the hospital to get them put into day treatment. And to me, that just was not okay. It just was not the way to go about addressing the needs of a student who was experiencing trauma, whether they're bringing it into the schools or there was something happening in schools that made it happen. And going back to Dr. McCoy, I should let you know, my high school students, when Michael Brown laid in the street, they walked out. They laid in the halls for the same amount of time that Michael Brown laid in the streets. So that happened in Ferguson, but the impact was still felt by my students in Minneapolis. And so having those services and support and teams to go out to work with students to help them process this information is really important. That's why having a strong relationship and collaboration with these outside agencies really matters for school districts. You can't go it alone. You can't.
So true. I think you started with a great point there, Dr. Johnson, that it's not that all students are mentally ill. When we talk about mental health education or services for students, I think we like to think of it as a force multiplier, right? It's helping you to be able to be your most successful and really live up to your potential, because we all experience challenges. There's not a person that's going to go through life without experiencing challenges. So do we know how to best operate under those conditions? Have we learned the skills? Because a lot of these are skills that have to be taught. And you're talking to that, you're speaking to that. And by starting earlier, whether it's, pre-K and social emotional learning, whether it's having the wellness center right there, being able to do that outreach to families, I think that this will be really key for changing the way we think of schools as a place for a whole person, not just your academic success. Right. maybe you could tell us a little bit about how you were able to determine that the mental health needs of students of color were not being appropriately met. You spoke to that a little bit about how, students were being taken to for treatment by police, and that might be further traumatizing. But maybe what kinds of policy changes did you make to help meet the mental health needs of Black and Brown students? Dr. McCoy, do you want to start?
Definitely. Within our school-based health clinic, we required an assessment every time a kid walked in the door. So there was data collection to the home environment, the classroom environment, because in many cases, students were dismissed from class for issues that what I would call fall in the gray area of respect and compliance, not something that's black and white, like you stabbed me, you punched me, but more so
Right.
like how you responded to me, and now I disagree, let's get you out. And so the data collection through the health-based school clinics helped us to know so much. I was shocked when the data collection from the health-based school clinics showed that 80% of the kids coming into the clinic and even our nurse's office were asking for food, which was showing home from the house by 9:30 in the morning. That data collection was like, it showed us a picture of their ecosystem, their world, and their issues, hotspots.
Kids are hangry, right?
I was saying they're angry. Absolutely, they're angry.
I understand that.
Right.
Yeah, that's exactly right. So we leaned into that, and it helped us greatly. We did a community needs assessment. But here's another thing that I often advise people to do in any role. You have authority, you have authoritative power, and you have influential power. So use that influence to get people to do something extra. Use that authority to create something extra. Every time I had a student death or a staff death for that matter, I created a program in memory of that person that helped to address that issue to help it not ever happen again. And so you mentioned, Amy, about preschool, and we started a preschool through third grade mental health program. We were the first in Missouri to pilot it, the third in the country, and that was just 2 years ago when we piloted, called Parent-Child Interaction Therapy, with a psychiatrist helping to do 3 to 4 things: create boundaries in the environment that the child knows I can't go past it, to create belonging, a sense of belonging. Here's my role. This is my purpose. So you don't have temper tantrums and spats and kicking and screaming and spitting and so forth. And then to create ultimately a sense of true belief in yourself and understanding the good expectations that go beyond your family environment's teachings, because people don't know what they don't know. And so that's parent-child interaction therapy, where a psychiatrist literally had a bug in the ear of the parent and was coaching the student in the middle downs on how to do that. Then we took it to the teacher level, because let's be frank, the majority of teachers are middle-class individuals and the majority are women, and you're dealing with over 50% of people who are not that, over 50% of color, over 50% male. And so you needed teacher-child interaction therapy for pre-K through third grade. And those forms of tips, tools, and techniques of the 4 to 5 Bs made a big difference, to stay on that theme of Bs. So data collection is key, and then creating something to not have the tragedy or the repeat of epidemics, that's essential.
So I'm gonna jump in, if that's okay. I'm with Dr. Art. I think when you're talking about the Bs, I'm gonna talk about the reason that I got to this. I had a really smart school support person who tapped my shoulder and said, we need to do something different. The fact of the matter is, we rewrote our whole behavior policies because we also were collecting data. The majority of suspensions of kids being pushed out of the learning environment, which for our earliest learners shows that school is not the place for you to be. So we're socializing kids to see that school is not for you. So why do I want to be there? So we took out the subjective ways of suspending kids, disrespect, disobedience, all the triple Ds that I now can't draw the third D. And the fact of the matter is that we saw that happening all the time. Kids were being pushed out of the learning environment, and then they would come back and the behaviors would continue. We hadn't addressed the behaviors. We hadn't given teachers strategies. So we required that our mental health providers provide like 20% of their time to professional development for the entire school staff. So that was everybody, teachers, the specialists, everybody in the school got that professional development. And then the assessment that you did with the individual students working with their parents, then the teacher got specific strategies. Another thing that came up was this whole thing around confidentiality, data privacy. So the information went to only the teacher that needed to know and the parent, because keep in mind, I was dealing with an issue that was really prevalent that our parents and families had this kind of fear of mental health. I mean, this whole thing about mental health being a strategy was not something that people believed in. And so we had to break down those barriers. But going out and talking to the faith-based communities, talking to the community at large, parents, I mean, all the things Dr. McCoy is shaking his head to, you cannot do this in isolation in your office, and just say and decree it. But the authority and the influence, absolutely, you have to use that. I sat on my academic leadership team every week. I felt like that was a priority because academics was what our business, a core of our business. And I looked at every suspension, not personally, but I had my academic team. We looked at every behavior referral across the entire system, pre-K through 12. We read them and we found something alarming. We found that for the same student, for the same school, the same behavior, we saw different outcomes. So if you're a white student that did something, I had 70% students of color. If you're a white student that did something, then there were, excuses like, oh, his parents are going through a divorce, or he was promised a trip to France and they're not going now. Some of those kind of things. If you're a Black student, they're just disobedient, they're bad, they're inherently bad. They don't know how to follow directions. And so that dichotomy of what we thought of our kids, I felt also played out in what happened. So you saw students being suspended in droves, pushed out of the learning environment. And we started to be able to look at the data for every student that was suspended, especially in ninth grade. If a kid was missing school in ninth grade, we knew right away that kid would have a less of a chance of graduating from high school. So how do we change some of that? And the Office of Black Male Student Achievement was about just that, the negative narrative, all the messages that you hear about Black males in our community and nationally. How do we reverse those and give our students a sense of pride with their accomplishments and try to reverse those messages that make them feel like they are not worthy of praise and engagement and support. And oh my gosh, I'm so happy you all invited me and Dr. Arthur here. I really am.
Yeah.
Really, really important.
Trailblazer. She's a trailblazer because I recall going to LA to help institute the same Center for African American Males a year after you started. So you were doing stuff that really everybody began to model. So thank you for your leadership.
Thank you.
Well, we need your advice. What advice do you have for state education agencies as they're planning reopening as it relates to mental health, the school, community, educators, staff, students, and even reaching their families? I love that you said going into faith communities, getting out the message, even when maybe families are a little hesitant to adopt these practices. What advice do you have for those agencies thinking about what it could look like as we try to use this opportunity to transform education?
Well, what I would say about agencies, quite frankly, even here in Minnesota already, they've been out talking about how do we use the resources that we've gotten. Yeah. They come with a plan already, and not a plan that does not represent the actual needs of the institutions that they are supposed to be supporting. And so again, getting out, talking to the people, looking at the data and the research, not being confused by it, not ignoring it, and making sure that, like Dr. R said, this pandemic has affected all of us. So what's important is that we create opportunities for people to reteach how to do school. And we know teaching students how to do school is a white way of doing school, to be honest. And we also know that relationships really matter. And so anything we can do to teach and help our teachers who want to do the best they can, help them get the skills and the resources that they need to build their own individual capacity, but the capacity of the schools and the organization to meet the students, the needs of students. And I happen to sometimes be in a district, in a state that doesn't believe that mental health is a need. Mm-hmm. And so if you don't believe it's a need, you're not going to go out and ask about it. And so that's a challenge that I think we have to get over. And so our legislators and superintendents and other people have to show up and talk and express what they need. And sometimes the people don't get a chance to do that. And so I just know that it's worthy work and it's challenging, but it's doable.
Yeah, definitely. And my advice would be, and I know we have about 3 minutes left, my advice would be to ultimately incentivize through policy collaboration, so that, in our system, we had about 20 agencies wrap around us with wraparound services. And those agencies received money, which would be like CARES Act money now, but it was a children's fund created. They received money to support the district that had the identified needs with the greatest amount of challenges, both in the home environment, but also in the school environment. So in your policies, focus on the ABCs and the ABCDs, academic achievement or the lack thereof, then support them with support. And I don't call it mental health as much as I call it life coaching, to address the stigma of health. So when you say life coaching, everybody wants a coach, everybody understands who and what a coach does. You need a coach through life, just like you need a coach for basketball, baseball, lacrosse, and so forth. So the academic coaching, then the behavioral therapist, behavior interaction, parent-child interaction, that's all behavioral, routine, expectations, boundaries, borders, patterns. Then the C, you need the C for individual character development, but also you need it for a culture that makes each school a center for healing engagement. So we also tackled that suspension issue, and I said just no more suspensions, period. For anybody through 8th grade, they all went to art therapy through in-school suspension. They all went to an alternative placement if they had situations that were larger and safe schools violations, with certified therapists there as a routine weekly and life coaches regularly. But the last place they need to be is at home. Right. Place that anybody, no, that doesn't work because they don't stay there anyway. And so and then the D is, of course, focusing on discipline strategies. That's the D. So you can often see that a person is crying out for help and that a system needs structures if the discipline is out of whack.
Absolutely.
Specific place. So that's the policy focus, the ABCDs, in my opinion, that we need to wrap around.
I love that. Dr. Johnson, when we spoke before, you kind of made the case for why schools are really a great place to address some of these. You talked about, adherence to appointments and things like that. Maybe you could just give us that last pitch on why school really does work as a place to meet some of the public health needs of our community.
Well, yes, exactly. Because schools, that's the place where our students show up every day if they have great attendance. And the fact of the matter is that what we saw is when students had their therapy needs met at the school, that they were more apt to make their appointments. They were more apt to be able to practice the skills that they were learning in therapy in real life, in real time. And so that is really, so it's not like you're going out and getting coached somewhere else, getting coached to play basketball on the hockey field. You're getting coached to play basketball on the court. And so that was really important. And it gave the therapist an opportunity to have time to connect with the child's teacher. And so it really provided this kind of environment where the child could attend therapy, learn strategies, practice strategy, get feedback from the teacher. And it had the cyclical effect of really making the students stronger and making the teacher stronger, because keep in mind, even though she's learning this skill with a child, Brandon, I always use my kid's name, Brandon, she'll be able to use that same strategy with Brianna, with another child. So the teacher's developing the skills that he or she can take on forward as well. And so having that mental based model is really important. And it takes some work, space, all these things that people bring up as problems, that this is when you have to use your authority. Forget the influence. You have to say, you will provide space for this. You will do this. And I think sometimes leaders, because we talk about this collaborative leadership, we talk about this, but sometimes you just have to tell people what they have to do. And you can't be shy about it. You have to be forceful. For these reasons, we're doing this, this, and this, and you will do that, that type of thing. Dr. McCoy knows what I'm talking about, and so people, Minneapolis, people don't like to be told what to do. But it really, I would say that we saw improvement in suspensions, but disparities still exist. We saw an improvement in outcomes, academic outcomes. We also were able to identify things like when students were having academic challenges, like in reading, etc., they would act out. They act out to get put out of classroom. So you have to meet the academic needs. And we got so good at, we knew if a child missed 8 days of schools out of the learning environment, that had an adverse impact on academic achievement, which we should know, but we knew it down to 8 days. 8 days of out of school had an adverse impact on mathematics because it's such a sequential content area. So collecting that data is really important. And this is such a good topic. I know we never have enough time. So
no, I couldn't agree more. I love how it's just down to the details you were. Just collecting that data is so key. And thank you both for providing the models that really can provide that for so many other schools that are going to look for those public-private partnerships, for ways to bring those health centers into their buildings, or even just to start by collecting the data so they can display the need and demonstrate that the need is there and look for ways to build it out. I think you've done a fantastic job highlighting, and we could really get into and dive into all the many facets of how you've been able to address trauma-informed care in your schools and make a real difference for those students. But this was a great start. So thanks everybody for tuning in, and thank you both for your expertise.
Wow, that was an incredible panel, and we're so glad to have Dr. Johnson joining us live today. So please put your questions in the chat for Dr. Johnson, and please accept from one grandmother to another my heartiest congratulations on the birth of your brand new grandson.
Thank you so very much.
Most welcome. Yeah, we're so happy to have you here today. So
I'm happy to be here as well.
Well, good. We heard from our panel previous to you and Dr. McCoy and Amy Kennedy, from many of our staff members about gathering information for the school report that MHA just put out. And one of the really important components of the report was asking students what it is that they want and what it is that they need. In your schools, when you were superintendent, how did you include the students in the processes that you put into place?
Well, we, in Minneapolis, we were really good at collecting a lot of data. So we had a student survey where we asked students about their experiences in schools. And I'm happy to report to this day, after talking to the research evaluation guy, they're really, they're asking, it's voluntary now, they're asking teachers to report themselves about what they think about students and students about what they think about teaching. And we're trying to match that and show how it matters so much to how students' sense of belonging matters to being in schools. So we just collect data, and as a part of the teacher evaluation, we worked with Ron Ferguson out of Harvard University to develop a student feedback tool that could be used as a part of the teacher evaluation process to hear from even our littlest learners, our kindergarten students, about how well they were experiencing the classroom environment. Because we know students know better than anyone else what's going on in the classroom.
They sure do. And as our screening data shows, students know what's going on with themselves and how it is that they're feeling. So it's so important to have their input. We've been working really hard at MHA to make sure that we can have alternatives to police response when a youngster or an adult is in crisis. It sounds like you've really helped to put that in place in the schools in Minneapolis. Can you talk a little bit more about that, please?
Yes, I mean, we were increasingly concerned with the use of police as a deterrent. But also, we found out after me talking to police is that they were being called in to handle discipline. And I had to remind the school leaders that they're the disciplinarians, not the police. The police are there for illegal activity, not for discipline. And so I saw that happening. And so we decided that we would depart ways with our SRO officers, but prior to that, we thought we were doing a really good job because we decided when we worked with the city, with the mayor and the police chief, that we would write the job descriptions and that we would participate in the interviewing of the SRO officers so that we knew they had some experience working with youth and some experiences, with, doing sports, community activities with youth, because police are trained to be police. So they're trained to do what they do well. And that is, be police officers. And we need our students to learn from their mishaps, to learn how to change their behaviors. And the only way you can do that is by teaching them to do that and redirecting them and explaining why what they're doing is not right. It's not you get cuffed. It's more of you get a hug and you get shown and told what's right and what's possible for you.
Absolutely. It's so important for everybody in the community to get to know each other. That's a wonderful way to have the SRO officers participating in the community outside of school. That's really important. One of the questions that we've had come in is around coalitions in Minneapolis. And we've talked a little bit about how you've included the students, how you've included the teachers. How did you include other coalitions in Minneapolis in the types of reform that you instituted in the school district?
Well, first of all, we thought it was important to go out on a talking circuit, like out presenting to various organizations, and there are quite a few in Minneapolis. We had like the faith-based group, Isaiah. We had like the African American Leadership Forum, and I'm not going to name all of them, but we were willing to go out and talk about the need and what we needed to do, and more importantly, to talk about how these organizations could help us and give us feedback on what we were doing. And so gathering those folks around the table, presenting the data, showing the evidence and the need to do something different. And of course, who could argue with it, really? No one could. And I think that we had a lot of support for doing what was right because it was student-centered. It was based on student success. And so we had different people around the table supporting us doing that. And of course, we had to go back out and report our successes and what we were doing, what was working and what was not working as well. And so even though we felt like we did everything in the beginning to look at how SRO officers were functioning, who was serving in that role, we felt from the community that we needed to really stop having SRO officers. And so we worked out, as I was leaving, we were working out a plan to reduce them initially. So we started to reduce them across the city in our schools. And I think now they probably have removed them completely. Because if you think about it, the city police serve the schools already. But we had put in additional resources and support to have people located in the building. So, it's something you have to include the community in, especially when you're talking about
Absolutely.
mental health as well. Mental health, because there's such a stigma in some of our communities, especially our communities of color. So it's really important that we engage them right away.
You touch on really important points. We have 1 minute left, Dr. Johnson. How about families?
Yes.
What was their participation in the process? And the community, the support from the children's families, from the students' families?
Well, the families, especially the families where they were taking advantage of the services, felt like it was great because they didn't have to go to work during the day and then go somewhere for mental health support after school. And I felt like from families, we could see the change in their students' behavior. You could see the change in their interactions within the school community, but you could also see the community understanding better how to work with families and parents and students who needed that support. And students who may not have been getting the support, the teachers were able to implement services and support that helped all students, which was really amazing. And so parents could observe that.
We truly appreciate all the work that you did and the wonderful model for school districts all around the country. And thank you so much for taking the time away from your brand new grandbaby. And please do enjoy your family.
Thank you so much. I will. Thank you for having me. Okay.
Indeed. Thank you, Dr. Johnson.
Thank you.
You're welcome. It's my pleasure now to introduce Amy Malloy. And Amy's a consultant with our MHA in New York State that was mentioned by our staff panel and that plays such a prominent role, the work they did in the school report. And Amy's going to give us a very brief update on the work happening in New York State around collecting data. And then we're going to move into a break. We've been sitting here for a long time. We'll have a short break and we will be back with our Regional Policy Council representatives after we hear from Amy and take that short break.
On behalf of the Mental Health Association, New York State, I'd like to thank Mental Health America for the opportunity to speak with you today. 3 years ago this summer, New York became the first state in the nation to require schools to provide all students with mental health instruction as part of the K-12 health curriculum. At that time, we never could have imagined how important this law would be. As students, teachers, school staff, and families manage the demands of remote instruction during the COVID-19 pandemic, mental health remains a core part of New York State education. Arguably, it became even more important. As the leading advocates for this initiative, we continue our commitment to promoting mental health literacy across the entire school community through the work of our school mental health resource and training center. The training center was established with funds from the New York State Executive and Legislature in July 2018, the same time the law took effect. Our staff help provide technical assistance to schools for curriculum development, training for faculty and staff, education for families and caregivers, and connection to community partners. To date, individuals in nearly 90% of public school communities have accessed our resource center. Our work would not have been possible without the collaboration of key professional member organizations, such as New York State school boards, school psychologists, school counselors, administrators, health educators, nurses, and so many more. They've helped our staff connect with their members to support proper implementation of the law and have informed the work of the Resource Center so we could be more responsive to the changing needs of schools. For example, this summer, our staff traveled around the state providing the opening presentation at the New York State School Board's Summer Law Conference, encouraging Board of Education members and administrators to prioritize mental health as they develop their reopening plans and determine how best to use federal stimulus dollars. In addition, we serve on several statewide work groups focused on suicide prevention, school mental health, school safety, and trauma. Our objective always is to help schools understand how mental health education of students, staff, and families aligns and supports other school-based initiatives, such as diversity, equity, and inclusion, bullying prevention, social emotional learning, and positive school climate. So what kind of impact are we having on mental health literacy? This past January, we worked with a contractor to survey education professionals, families and caregivers, and community providers. We asked about their knowledge of mental health and had it changed in the last 2 to 3 years. We received responses from 50 of New York's 62 counties. 82% agreed that their mental health literacy had improved. 84% said that they learned a new coping strategy. 83% agreed they had a better understanding of both youth mental health and their own, and 79% agreed they had a better understanding of how to access help for themselves and others. While these responses do not indicate a correlation with either mental health education being taught in schools or the work of the Resource Center, they should provide us with hope that the public's understanding of mental health is changing. And as research indicates, that will help us reduce stigma and close the nearly 10-year gap between the onset of symptoms and accessing treatment. We're encouraged that mental health education will make a difference for our youth today and generations to come, but we know there's more work to do. So alongside all of you, we will be continuing to advocate for required teacher mental health training, excused absences for mental health, and an increase in prevention and treatment services in New York schools. In addition, we're always happy to partner with our colleagues across the nation. The Mental Health Association in New York State can be a resource for you in bringing mental health education to your state or community. Visit us at MHA.nys.org.
Welcome back. Now you'll have the opportunity to hear from our Regional Policy Council representatives. We have Barb Johnston from our MHA in New Jersey, Ben Harrington from MHA in East Tennessee, Shauna Mulvihill from MHA Minnesota, and Mo Keller from our MHA affiliate in Colorado. I'm going to turn things over to them, and then they're going to join us live for what will be a rather brief, I'm afraid, but brief conversation. So if you have questions about anything that's going on in their states, or you want to ask questions about your states, please put them in the chat now. Let's hear from our regional policy representatives.
CEO of the Mental Health Association of East Tennessee. I'm really pleased to be able to be here to talk a little bit about mental health education in schools. So really, what is mental health education in schools all about? It's really about changing what people know. And of course, that is the foundational pillar of the before stage 4 philosophy, changing what people know. So it starts with changing what adults know, as well as what parents know, teachers know, but also about what students know. We've been doing Mental Health 101 in schools since fall of 2000. So we've got 21 years of experience understanding what we're able to do effectively with young people in our classrooms. And we're teaching middle and high school age kids. And so we know that in every classroom, not just in Knox County, Tennessee, but all across Tennessee and really all across America, there are going to be kids that are demonstrating symptoms of depression. They're sad, they're hopeless, they're maybe contemplating suicide or planning a suicide attempt, or worse, have actually attempted suicide. So we know that over about the last 10 years of YRBS cycles, YRBS is the Youth Risk Behavior Survey that's administered by every state for CDC. We know that we've been able to change some of that. And so with our mental health education and school program, we're not looking at change from a YRBS cycle 2 years ago to the most current one. We're really looking at across a much longer, broader period of time. So that's why we look at this last 10 years, last 5 YRBS cycles. We know we're able to make a huge difference. We're able to change some of what's going on with kids. So we're able to reduce the number of kids that met the criteria for depression down from 9 to 8. We've been able to reduce suicide contemplation by 20%. We've also been able to reduce suicide planning by 25% and suicide attempts by 50%. So there is a significant return on investment. We know Mental Health 101 costs about $8 to serve each child that we serve in our program, whether it's in middle schools or high schools, whether it's in Chattanooga, Knoxville, or up against the Kentucky and Virginia borders. Does not matter. It costs us about $8. We spent about $351,000 on this program to serve 32,000 students at 125 schools across Tennessee. What we do know is the significant return on the investment. We point to one county, and that's Knox County, Tennessee, which is the 3rd largest school district in the state, and the county where we have the most presence with the Mental Health 101 program. It's a mandatory deal in every middle and high school. And so we know we're able to reduce suicides by about 150 suicide attempts in this one particular county. Now, suicide attempts have really 2 factors of cost. There's the healthcare costs, admission to an emergency room or admission to the hospital, that sort of thing. But then there's also the work loss cost associated. And you think about that as, a young person attempts suicide. Well, you better believe the parents are going to drop what they're doing. They're not going to be at work. They're going to be at the hospital or going to be with that young person when they're discharged. So there is a work loss cost as well as the healthcare costs. Bottom line, for every dollar we're spending on our early intervention in schools program, we're saving $17 to the community, to families. So the family benefit, of course, is absolutely priceless. Now, so what are our success indicators? Well, we know we're able to change what people know because we pre and post test the students in our program. So we're able to know the ability to recognize symptoms increases in those students, the ability to identify, that's a demonstration type question, identify the exact symptom duration requiring their intervention with a fellow classmate, a family member, or even for themselves. It is something that increases. And so those are really good indicators that we're able to monitor, year in, year out through our pre and post tests. The longer term indicators would be those things that are measured through the YRBS. And so we're able to see a decrease in folks who are meeting the criteria for depression, or decrease in suicide contemplation and suicide planning and suicide attempts. Also, the number of youth suicides has decreased as well. In some years, we've actually had 0 teen suicides in Knox County as a result. So I don't want to traumatize you, but this is sort of like a little bit like high school physics. If something goes up, something must come down. So what goes up is we change what people know about mental health, and the corresponding decrease is a decrease in suicidality. That's all good. But if you're decreasing suicidality, shouldn't there be something else that goes up? And the answer to that question is absolutely. 2 things go up. And we know this over a 21-year period, so it's really important. Number one, the number of kids that start to seek and enter treatment increases dramatically because when we're talking about teaching over 20 years, 400,000 kids, that's a lot of kids that now start to seek help. So that's a big deal. But that ripple effect started to grow so profoundly that schools actually started to think about what they had to do to be a little bit more prepared too. Not only did they seek in-service training, that sort of thing, but they also sought to find partners in the mental health community to embed a clinician at a particular school, starting out, 1 day a week, that sort of thing. Now some of our providers have actually developed partnerships to have a clinician at every middle and high school 5 days a week, so that no child can go untreated or no child can be left to deal with whatever is the troubling situation that may have presented. So changing what people know causes the ripple effect, suicidality decreases, and more kids enter treatment. So if you need more information, here's my contact information. Please feel free to reach out to me, ben@mhaet.com. Thank you very much.
Hello, I'm Barb Johnston. I'm the Director of Policy and Advocacy for MHA in New Jersey, and I'm a proud member of the Regional Policy Council and the representative for a bunch of states in the Northeast. Happy to be here today with all of you to talk about mental health and schools legislation in New Jersey. I'm going to give you a little background for New Jersey, and I'm going to tell you why it's relevant later. But New Jersey is a very densely populated state. We have 565 municipalities. We have 686 operating school districts, about 2,500 schools in the state, an enrollment of almost 1.3 million students, and about 130,000 teachers in our state. And I'm going to, again, tell you why this is so relevant later. I'd like to just remind you about the very excellent policy recommendations that came out of a report done by Mental Health America, which is called Addressing Youth Mental Health Crisis. And they made 3 policy recommendations, which I'd like to just briefly review with you. One is prevention and mental health promotion options for states, with a focus on mental health in the schools. The second is to do early intervention and treatment integrated into schools. And the third is youth empowerment to drive cultural shifts. So these are important, and I think they're great to use as a litmus test for how legislation is measuring up in your own states. We did this for New Jersey, and we have 15 bills that are pending in our legislature having to do with mental health in schools. 9 of them have a focus on prevention and education. 11 of them have a focus on early intervention and treatment, and we have 1 bill focusing on youth and student empowerment. When we take a closer look at them, we have 2 bills that address suicide prevention, education, mental health education, all targeted to higher ed, to the college and university populations. We have 1 bill that targets mental health education in middle and high schools. And then we have another one that's a pilot, which goes from kindergarten through 12th grade. We also have a resolution on board that is supported, which wants all of the boards of ed to support the mental health recommendations in their districts. You can see there's a number of prevention and promotion bills. On the early intervention and treatment side, we have a bill on depression screenings. It's been a controversial bill that's been on under discussion for a while. We have a bill on substance use screening. We have a bill on excused absence, and I'm going to talk about that later. And then we have 2 bills that very importantly survey resources in the districts. 4 bills that support school-based counseling, a very, very important component for students. We do have 1 bill which addresses higher ed, the university level, and trains student mentors on campus. So this is just all background, and this is really the meat of my presentation, because all of this background helps you to understand what are the questions that you should be asking about your legislation on mental health in the schools. So first and foremost, are students included in the planning and implementation? And most of the time the answer is no. And we know that even from everything we do, unless we have participation from student bodies, from all of the stakeholders, the likelihood of success is diminished. So students need to be included through councils, through advisory groups, not only in the planning, but also very importantly in the implementation, especially students, individuals who have disclosed, who are individuals living with mental health conditions in the schools. All of this is really important to include them in both the planning and implementation. The second question we want to ask ourselves is, does the initiative or program reduce stigma, or does it create stigma? So here's an example. So there are some very good excused absence bills. I know Colorado has one, Utah has one, all good examples. We're not happy with New Jersey's bill. We think it doesn't necessarily comply with parity. It requires, it leaves it up to the commissioner to identify some certain conditions, and it requires documentation that may not be the same as required for physical health conditions. So we want to make sure that any of these excused absence bills meet the parity test, that they are no more complicated and have no more stringent requirements for physical health care conditions. Again, another important test. Taking a look at all your programs, are they opt-in programs or opt-out programs? We have a depression screening bill that was opt-in, then opt-out, and right now it's an opt-in program, but ideally you really want to have programs wherever possible that are opt-out because of, again, the stigma and better to have many more people participating on a program where all are included initially. Funding is critical and resources are critical. So we're educating on these programs, which is very, very important. And we want to make sure that we have the funds to carry out the education in a timely way, in a quality way. And we want to make sure that once we raise these issues, we know where people can go for assistance and help. Another key question is what opportunities are created for education and dialogue with legislators and staff? And if you ask me, this is the most important point of my presentation, because any bill that has to do with mental health in the schools is a wonderful opportunity for all advocates to open up dialogue with their legislators. So if there is a bill, you can make a bill better with amendments by educating the legislators and explaining why. If there's people who may not be aware, it's a great opportunity to open the dialogue with them and their staff. So we think all of these bills, of course, could always be improved, but they're all very good. And it's a great opportunity for education and understanding and support of the importance of mental health in the schools. And just referring back to my first slide and giving you all of those statistics, the question is, how can we think global and act local? Because we know that regardless of what laws are in place, we have those very many districts implementing, and we have very many teachers who will be following up with a lot of this. So you can see with 130,000 teachers and upwards of 500 districts, that it's really important to have good principles in place and have your legislation be as sound as can be and as realistic so it can be applied locally. And that's where the action really occurs. So those are our key questions that you really do want to ask yourself. So
hello, everyone, and welcome to the August 3rd meeting of the Regional Policy Council of Mental Health America. I'm Mo Keller, and I am the Director of Advocacy for Mental Health Colorado, our state affiliate for Mental Health America. With regard to elementary school and early childhood education, advocacy, and legislation, we have been very active over the last few years with multiple efforts and with a lot of partners on improving emotional and mental wellness for children. And so we approached this from 4 different avenues. We went from a funding piece, funding and expanding existing programs. We went through an education of teachers and staff, administrators, and parents, and also allowing for the sharing of information between school districts and mental health centers. We went to early childhood consultants and even the creation of an Office of Early Childhood in the Governor's Office. And then we looked at suicide prevention efforts. So those were our 4 areas. So in terms of the funding piece, in 2019, we had 2 bills that we did get passed, but were delayed because of COVID and are now just again getting up and running. The first was that we allocated $3 million to increase the number of mental health counselors in public schools, K-8. We lost that money during the COVID economic downturn. We got it back this year. So we will start to see a lot more hiring of mental health counselors in the public schools starting in 2021-22 school season. The other bill was 1017, and this is for, it's called the K-5 Social and Emotional Health Act. And this one creates a pilot program to employ school mental health workers in up to 10 elementary schools that are going to be part of a pilot project that have high poverty and high need students. This was to begin in 2020, but now it's scheduled for this coming fall to be enacted. And what this bill does is it provides for a counselor for each grade level. So in these 10 pilot schools where there's a school here, they're going to be hiring, hopefully, 6 counselors, 1 for K, 1 for first, second, third, fourth, and fifth grades. So that there will be enough counselors to really deal with the emotional and wellness and mental wellness of all these youngsters. In terms of education of staff and students, Mental Health Colorado wrote this bill, Behavioral Health Training Requirements. So as you probably have in your states, teachers must have every 5 years a recertification to keep their license. So we were able to get into a bill last year, 2020, to have mental health, whether it's mental health first aid or suicide prevention programs, online trainings or in-person trainings, but there has to be at least one class on mental wellness for children and mental health for children in order for them to get their license every 5 years, or their relicense every 5 years. Then we also passed youth mental health and suicide prevention. Now, this was a very controversial bill, and it kind of still is. It also got delayed in implementation, but is starting to get going now. This was sponsored by one of our big mental health champions, Representative Michelson Janae, whose 10-year-old son many years ago attempted to complete suicide at school. And it shook her and her entire family. And she has been a champion on getting better mental health services for children since then. She said, what if my son had only had one person in the school building to talk to? This attempt might not have happened. And so she had, what this bill does is it allows a youngster age 12 on up to be able to access mental health counseling in the school during the school day without parent knowledge or consent. This is, you can see the controversy here. The counselor is required, there's a set of criteria here, the counselor is required to notify parents if it appears that the child is unable to cope because the particular condition is too great or threatens suicide. Then they must break the confidence of the child and notify the parents about it. They also are required to encourage the child to consent to bring parents in. A lot of mental health professionals said when you work with youngsters, eventually you have to bring in the family and the parents to do a complete group and work with the whole family in order to be able to assist the youngster. And so they pushed for that part, and that indeed was part of the bill in the end. This was a couple of years in the making, and it also, the other good thing about this bill is that it requires a lot of data collection, not anything that is proprietary, but just in aggregate numbers to see, is this really an issue for which a lot of children are asking for assistance or not. And then another bill that we wrote, the Enhanced Safe to Tell. You may have in your state the Safe to Tell call line, which is an anonymous call line that goes to law enforcement. And this started after the Columbine shootings because it was discovered that a lot of the students knew that that certain individuals were in trouble or were planning something, or there was something in terms of school safety. And so we have had hundreds and hundreds of calls ever since. This has been, Safe to Tell has been in place for at least 10 years. We have found, however, that within the last couple of years, the number of calls that were coming to the Safe to Tell line that dealt with public safety, such as someone's going to bring a gun to school, there might be a bomb, that kind of stuff really dwindled. And the majority, 86% of all the calls that now are coming into Safe to Tell were mental health related. I'm worried about my friend's thinking about suicide, I'm worried about suicide, someone's worried about their child, that kind of thing was coming in. And yet we still had law enforcement as the responders. So the police would show up, of course they're in uniform, which scares everybody, and they're trying to talk to a 10-year-old. So we bifurcated that. So what the bill does is it separates the calls. So the person calling Safe to Tell will still have the same number, but when they explain what it is, All those calls involving mental health will go to our mental health crisis line, and they will respond with peer support or with the mobile unit, which will consist of a mental health professional, and the police will not respond unless it appears that they have to come for backup. So years ago, 4 years ago to be exact, we were part of a large coalition of individuals, which included the Autism Society, as well as developmental disabilities organizations and us. And we met about a problem we were seeing, and that is that a lot of school districts were increasing the number of youngsters in daycare, preschool, up through second grade, expelling them or suspending them for behaviors. Could be tantrums, it could be emotional outbursts, it could be a youngster just not knowing how to deal with stress or anger that they may have. And so, but they never got any treatment or referral, they never got any follow-up. And so what this bill does is it prohibits a school district from expelling a student in preschool, kindergarten, first or second grade, or imposing out-of-school suspension unless there's three factors that it really does have to occur. The student commits an action that could endanger others on the school property. Failure to remove that student would violate a safety threat that cannot be reduced or eliminated through modifications to manage the behavior. Enrolling entity has exhausted all other appropriate and available behavioral and disciplinary actions. So that's what that does. I do want to mention that we have been working with the school districts with this bill on providing for consultation that comes from the Colorado Department of Education. And it also works with them on a needs assessment and then an improvement or performance improvement plan. So those steps that a school district is required to take, they will have assistance from the Department of Education to have some specialists come out and help them with that. So then we went to some early childhood consultants idea. This brought us, that bill brought us to another idea. And that is that, and this is a Mental Health Colorado bill as well, we created a statewide program of early childhood mental health consultants who will be able to mentor staff at daycare centers, preschools, and other early childhood facilities. And this was kind of an outgrowth because so many of the school districts in the previous bill about not being able to suspend a youngster said, we don't know what to do. We're in over our heads here. We don't know what to do. And so besides all of the strategies that the Colorado Department of Education is going to be doing with those school districts, we created this program, which is a standalone program that hires mentors. It will be through the Colorado Department of Education that these folks will be hired, and they will go out, they will drive around to these different daycare centers or preschools and mentor staff, hold classes for the staff who work with youngsters at this age to come up with good strategies and to work in real time, when the youngsters are there, to show how all of this works. This bill was watered down a lot because of COVID last year, but we beefed it up again this year, so that's starting to roll as well. And so then this year, the governor was very interested in this. And so there was a very, very large stakeholder group, of which we were one, to create a Department of Early Childhood in the governor's office. And so we as Mental Health Colorado are on the committees to enact this legislation right now. And so this is a pretty interesting step, because we have a lot of different organizations. Some are public, some are private, some are through the state, some are through the counties, that focus on early childhood, but they're all disjointed. They're not working together, not talking together. And the concept here is to put them all together in order for us to be able to be more effective. So lastly, this year, we have something we call the Rapid Mental Health Response for Colorado Youth. This bill was again by the same legislator who did the age 12 and above access to health care in the schools, or mental health care in the schools, Representative Michelson-Janae. And when she first proposed this to us, I thought, holy mackerel, how is she going to do this? Her interest was to have every youngster who wants to, so it's voluntary, in the entire state, have an anonymous screening and then referral, if it needs to be, there needs to be one, to a mental health specialist for 3 free mental health counseling sessions due to COVID or due to all of the anxiety, isolation, the feelings of isolation, depression, anxiety that children have felt through this COVID piece. And this all has to be in place by this month in order for kids to be able to screen. So there's a voluntary screening on the state portal. If the child scores high for anxiety or depression or other need, then the professionals are now contacting our Office of Behavioral Health to volunteer for this program. They have to be certified already, which they would be, and they're creating a list, so they will be ready to be referred, to have a youngster referred to them. The state will pay them out of general fund, but they will provide the service of the counseling to the youngster free for 3 visits. If it looks like after those 3 visits, the child is engaged enough and involved enough that they need more, they can go up to 5. And we're a little unclear how that's going to work out yet, because we don't know how much monies we will be spending until we see how many kids actually do take the voluntary screening, which is on the state portal. So all of this has to be done by the 2021 school session, which starts at mid to late August. So everybody is in hyperdrive to get this running. So those are the things that we have been doing. There's a lot on our plate. But if you would like any further information, this is my cell number and my email address.
Hi, everyone. My name is Shannon Mulvihill, and I'm the Executive Director at Mental Health Minnesota. And I wanted to talk just a little bit today about our efforts around youth mental health here in the state of Minnesota. So Minnesota has one of the oldest school-linked mental health programs in statute. That was first passed and funded in this state in 2007 by the legislature. And that program has expanded considerably over time. And we've been really proud of the fact that we have been a leader in Minnesota around this. Because we believe that mental health in schools and providing access to students is incredibly important. So I'm going to talk just a little bit about our school-linked mental health program as well as a few things that we think we would like to continue to work on here in the state of Minnesota. So as I noted, we have had a school-linked mental health program in Minnesota since 2007. That program has expanded considerably over time and now definitely includes a lot of evidence-based practices, particularly around trauma-focused care. And so we are paying attention to what needs to be continually improved in the program. I will say that I think some of our best advocates for this program have been teachers, superintendents, principals, parents who have really seen the significant benefits of this program. So the way that our program in Minnesota works is that we co-locate community mental health professionals right in the school buildings. And so the goal of that, of course, is to remove a lot of those barriers around transportation and other things. It also, in our view, helps destigmatize the use of mental health services because it's just another office in the building. So it provides a lot of great support to school counselors. We don't have enough of those. No one does, but it does provide a lot of great support and some place for them to refer students who may need some more help. So as I said, we work closely, our school districts do, with our community mental health providers to have providers right in our schools. Right now we are in, I believe it's about 80% of school districts across Minnesota, and about 50% of our actual school buildings have a mental health professional located right in the school to help and work with students. The program is funded in Minnesota in a couple of different ways. Because we're working with community mental health professionals, they are able to bill both private and public insurance, and our state also allows for the use of Medicaid dollars for these services as well. Then we have grants available that go out to our school districts as well as part of this program to help fund the additional costs that come along with offering this service. And so predominantly those costs include students, the cost for offering services to students who either do not have health insurance coverage or who are underinsured. It also pays for other services that are usually not reimbursable. So that may include in-services for teachers, for example, or other training, outreach and communication with families because the treatment and therapy is happening right in the school. So that making that connection and continuing to have that relationship with families is very important. As well as, things like equipment and coordination of telehealth, which has become all the more important, certainly in the last couple of years. So the outcomes for this program have been terrific. We've really seen great use of the programs. About half of the children who are receiving these services have never received mental health services before. That number gets even higher for children of color. That's nearly 60% of children of color in the programs have never received any mental health services before. And so we do see these programs as an opportunity to narrow the gaps that exist in access to care, reduces the stress that's put on a family in terms of trying to get to children to appointments during the day. It doesn't pull them out of school as frequently or for as long because they're able to get services right in school. So we have continued to see the program increase, as I've noted. We also, this year, were able to work with the legislature to identify some extra funds that came in through federal dollars as some one-time money to help expand the program even more. We also were able to add some substance use services to that program as well. And so we are we are looking forward to continuing to grow the program and see it in every single school district around the state. I wanted to note just a few other things that we continue to look at and have continued to work on. One is suicide prevention work in our schools. And in particular, we have focused in the last couple of years around additional training for teachers and other staff within schools to be able to identify when a student may be struggling and understand the resources and referrals that they can make. And so there has been continued work on that in Minnesota, and we've made some good progress and have more funding available now for this next biennium to continue to offer that training. We use Cognito for that training here in Minnesota. It's an online training that is kind of situation based, so it actually kind of walks you through a potential interaction with a student. And so that's been a very positive thing for helping our teachers and other school staff and support staff to be as informed and ready as possible to help identify when a student may need some help. We are continuing to look at mental health education in our state. I have been really enthused about what some other states are doing. New York certainly took the lead on mental health education and making it a requirement. I firmly believe this is very important. And I am hopeful that in the next couple of years, we'll be able to make some progress on that here in Minnesota as well. It is encouraged in state legislation right now. In Minnesota, it is not required. What it does require is that the Commissioner of Education does need to continue to update the training that would be, or education that would be offered, and what the curriculum would be if schools do choose to offer mental health education, but they are not required to do so. I think we can point to the numbers in terms of what we see in our screening data, and I think many states, if not all states, are seeing very high increases in the number of mental health screenings happening in their states. We certainly have seen that in Minnesota, and our increases have been even higher among youth, 400, 500% higher every month in recent months over 2019 or early 2020. So I think that really speaks to the need to continue to use that data to push forward some of these initiatives like mental health education. The last thing I wanted to note that we are just continuing to look at is peer support for students. We do a few different types of peer support programs here at Mental Health Minnesota, and really see an incredible value in what peer support has to offer. But the limitations of it, are frankly, the fact that many of those who are providing peer support don't reflect the communities they may be serving. And so that makes us want to step back and say, what else can we do in terms of peer support? And given the topic at hand here, what else can we do to support students and help them be ready to support others, be safe sharing their stories, understand the resources that are available to them, and have good training programs that are realistic for students to participate in, and then serve their own schools and students in their communities.
Hello, everybody who's joining us, and hello to our RPC reps. And I know I've said this to you all individually, but if I haven't said it collectively, we really appreciate you and think you're all the best of the best. So we're so glad you could be here with us today. We really are running short on time, and I'm sorry about that. So I encourage everybody to be on your monthly calls who are our affiliates and otherwise contact you at your emails. But I'd like you each to give us, please, a 1 minute how you see the tie-in between what we've talked about so far this summer, how deflecting folks away from the criminal justice system and that education piece and school ties together. Ben, you want to start because you're top of my screen?
Sure. The thing is, the whole theme is about moving people away from the usual place where they enter the mental health system, and that's somewhere at stage 4 in a crisis, or unfortunately for some, in the backseat of a police car. And so how do you dial all that further upstream? You start with the very first stage of before stage 4, and that's changing what people know. And we got to start with kids, and we got to start with their teachers and other school personnel and families, because no one's going to seek help unless they really know that they need to seek help. And so it starts there. We've got to educate kids at middle and high schools so that they can help their fellow students.
Thanks, Ben. Barb?
Yeah, I ditto to what Ben says about early intervention for sure, but also I think, creating normalcy and reducing stigma for access to care, having people want to seek counseling, and there were so many ways that were discussed today to reduce the stigma, involve peers, and really make it a beneficial experience for people to really seek care.
Thank you, Shauna. You with us, Shauna? We're not hearing you. I'm gonna.
Yes.
There you go.
Can you hear me?
Yep.
Sorry about that. My internet off today. I would just lean toward screening numbers and really paying attention to what we're seeing. I keep talking about our screening numbers that we've seen increase significantly, and then any other population for youth, that we use that as something of a crystal ball. This is our moment to really look at what needs to be done, what the needs are, and how to meet those in our communities.
Thanks, Shauna. Mo, your state has so many of those pieces in place. I love it. EAP for kids, it sounds like in schools. But tell us more about how all the things are going to tie together, please.
Well, I really like what some of the speakers earlier had said, that you change the terminology, you change the conversation, and you don't talk about mental health, even mental illness. You talk about strategies and coping, being the coach. And so the more that we talk, especially with the early childhood piece that we passed in our legislature, where we have mentors for daycare workers and preschool and everything, that what you do talk about is that the youngsters is showing through behavior that that kid can't cope. So you bring the parents in and say, these are some strategies, these are some coaching, these are some for the emotional wellness of the entire family, because if the child's having problems, the parents are. So I like that approach about talking about coaching and talking about strategies to cope. And that's language that you can use all across the entire educational span.
Thank you, Mo. Thank you all for joining us. I'm so sorry we don't have more time today, but I want to invite everybody who's listening to what I hope will be our first meeting back in a long time in person on December the 1st in Santa Fe, New Mexico. And we'll be honoring some more state champion legislators, and all of our RPC reps will be there. In the meantime, they're always available to answer your questions, as are our staff members. I'm Debbie Plotnick. I'm happy to answer any questions or direct it to any of our staff members at MHA National. So thank you all for joining us today. I know I learned a lot, and I always learn a lot from our RPC reps. So thank you again. The Regional Policy Council wouldn't be possible without all of you. So thank you.
you.